you sit at either of those two spots there, or either one of those two. This is coming in here in a second. You good, Jasmine? You good? You good? Can you hear me? Can you hear me? Not at all?
How many questions per se?
Check, 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 check. Hello, 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 hello. Can you hear me? Let me put these on. Just check, see. Check, 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 check. Yeah, good work. So you start the broadcast?
Yeah.
So it's going live. All right, did you start those two? All right, just so you know, there's a camera in case you didn't see the blue light. All right.
Cool.
All right. You ready, Jasmine? All right. So, what's up, y'all? Welcome to the Sports Medicine Broadcast. We're broadcasting here live at the Memorial Hermann 13th Annual Sports Medicine Update. This is day 2. So here we have, I'm Jeremy Jackson, of course. If you listen normally, you know me. Here we have Dr. David Crumby, our orthopedic surgeon that we refer pretty much all of our kids to as long as I go. And then we have Miss Leslie Humphrey. She's going to be doing some of the interviews today, so she's jumping in, figuring out how we do this. So, Dr. David Crumby, tell us real quick about who you are and what you do.
Well, thanks for the introduction. Thanks for having me. I'm one of the sports medicine physicians with the University of Texas Medical School. Definitely affiliated closely with the Ironman with Memorial Hermann. I'm primarily on the southeast side of town with Pasadena and Pearland markets, as you know.
Yep.
But like taking care of kids with sports problems. So that's basically me.
All right. And then you should be able to see your son over there. It's Trey, right?
Yeah, come on.
Trey. So I think Trey can wave to the camera, say hi.
He's not really shy.
All right, so it's good to have you here, hanging out with your dad. So very cool. I love to bring my son up and hang out with me whenever it's possible. So, all right, so we want to talk to you today. You talked about physeal fractures, and I know last year I texted you asking about a physeal fracture because I have a 14-year-old kid and coming in, with like knee pain, and I really feel that I'm not qualified to test that out. Can you tell me a little bit more about the physeal fractures and what I need to look for, the ages of the kids, and is it something I need to look for in my 3-year-old son when he lands wrong and is hobbling or something like that? So just talk more about that, and then I'll ask you some more about the test or specific things like that. So
Okay.
Who are we looking for first?
Well, obviously, as kids, it can range from anywhere between, as you alluded to, 2 and 3-year-olds. Now, there are certain fractures that are more associated with elbow injury in the younger kids from falls. Really didn't touch on that as far as sports because it's not typically where you see those. So there's a higher injury falls. Certainly, there's the supracondylar fractures and that type of thing. But mainly, what you're looking for is, pain, swelling, inability to move the elbow. It's probably the most common with pain. And that you have to have a high index of suspicion. As far as being a bit uncomfortable with it, you're not alone for sure. A lot of the urgent care guys and are not used to seeing the X-rays of kids. They're not appreciating how the physes look. So they either look like fractures or they say everything looks good, but there actually is a problem. Sometimes you have a fracture through the cartilage and you can't see it. Typically with an X-ray. So it's important to get X-rays on both sides so you can compare the side that doesn't bother them per se, the uninjured side versus the injury side. And a lot of times that can elude or elucidate a lot of information that we really need to see and that type of thing. Also, I think it's important to include the activity level of the kid and their goals. If they're someone that can stand being in a cast so we can trust versus someone that we can't. And a lot of that conversation has to be with the parents, as well, obviously. But those factors or play a big part in what I consider when seeing someone with an injury to their elbow, particularly considering maybe a physial type injury.
All right. So you said the the guys in the ER, they're not especially comfortable looking at it as well. So what's something that if I was to take, one of my students or say, hey, there's a possibility you need to go get an X-ray. What's something that I could do to say, how can I communicate that with the X-ray tech or the people there to say, I suspect this. Is there a way that you can, double check it or, do the other side?
In a perfect world, I would love that we have medial-sided pain. They do an internal oblique view and all that. A lot of times we get no comparison view, and I have to do it myself. And so again, it's more the high index of suspicion, identifying that the athlete is in a specific age group where we have a high consideration for a physial injury, have early surveillance basically. So when you call me, I say send them. I want to find out it's nothing versus kind of think about it. I'm gonna sleep easier knowing that there's nothing when when there isn't anything there versus kind of wondering kind of deal. So commonly, and I say commonly, I'm being friendly. It's almost every single time that when we have an injury like this in this specific age group that we're getting additional views or comparison views from the other side or special kind of views that we'll do. And I don't expect the ER per se to really kind of elucidate that out.
All right, so how long after the injury do we have before there's a real problem with the physio? Because I know that you said when I came to visit you one time at surgery, you were talking about you had to go to the ER right afterwards to go take care of one of the kids because they had a physio fracture because it has to be done within like 48 hours or something like that. I can't remember specifics. Mm-hmm. How long do you have to deal with that?
It depends on the location. So certainly you want to reduce or displace physial injury as soon as possible. It's not a hour issue, but usually within 24 to 48 hours if it's displaced. And it depends on where. Some physial injuries you have a little bit more forgiveness, and others you don't. Certainly around the knee, definitely the distal femur, you need to get that. It needs to be anatomic. There's a high association with physio injury with injuries to the growth plate there versus in the distal radius or wrist. You're a lot more forgiving. Certainly there's common fractures involving physes in children or adolescents where we don't want to do a reduction if it's longer than 4 days. The studies show that if you reduce then you have more disruption of the growth plate versus leaving it where it is. And just dealing with whatever consequence or sequela that happened from a displaced fracture. And sometimes it's a malunion most of the time, or you have a physial bar where instead of partlets growing in the growth plate, you have bone actually growing. So then you get angular deformities, and sometimes you have to deal with that. And the peds guys can tell you more about kind of what they do with that. But certainly it depends on the physes and that type of thing. The biggest issue from an acute management piece is having a high index of suspicion, identifying that even kids in the 16 can have a physio elbow injury, for example. And if that's the case, then you shut them down, you ice them up, you splint them, and you send them.
All right. So again, I told you I don't feel like necessarily qualified. 'Cause I know I can do compressions and tap, and I can use the tuning fork to kind of test a fracture. But from what I understand, a lot of that doesn't test the growth plate or especially through the cartilage, that kind of thing. And in your presentation you said if there's diffuse pain and there's swelling and tenderness right over that area, that's just one of those things like you just have to make a judgment call and hope for the best. Or
right, it's not anything that we're going to be able to tell right when it happens, but it's more the high index of suspicion. So we're going to shut you down, we're going to ice you up, and we're going to get an X-ray, possible MRI, and kind of figure it out. That's really kind of what particularly elbow injuries are involved in, particularly in throwing athletes. Now there are other physio injuries like ankle and knee, and around the wrist and those type of things that we can have more of a knowledge of. But as I think you saw when you were with me in the clinic, we thought we had a ACL in a kid and a fairly older kid, 15, 16 years old. What happened was he actually fractured his femur through his growth plate. So with that, you go, oh wow, so again, they present a lot of times the same fashion as more ligamentous or more commonly ligamentous injuries, and then you get X-ray, and sometimes I have parents go like, well, no, I need MRI, why do I get X-ray? Well, that's the reason, because we need to make sure there's not a fracture versus a ligament issue.
Right.
And a lot of times that changes the whole discussion versus that kid, everybody was pulling on his leg and they were like, oh, he's got ACL, came in, and oh, I think I tore my ACL. I'm like, ACL is probably fine. It's your physis. You basically tore your condyle off. So we have to get him to a pediatric orthopedic surgeon to address that issue, and mainly not only just the acute part of it, actually the fracture fixation part, but also any potential surveillance for any problems with the growth plate later on.
Right.
I know in your talk you talked about, on top of physical fractures, you talked about OCDs. How often do you feel you see that in athletes younger than 12, and how often do you feel you have to do surgery on those?
Actually, probably more commonly, OCD lesions are treated non-operatively. I think a good surgeon should try not to operate on you.
Right.
Okay. So just having it doesn't necessarily mean anything. Certainly, if they're asymptomatic and I see it, then you leave it. The criteria for symptomatic OCD lesions typically alluded to how they present on MRI. So the MRI is a dumb X-ray, if you will. It bases or draws pictures based upon water density. So if I see an area where you have increased signal behind the cartilage flap or in the bone, those are the signs of an unstable lesion, particularly if they're symptomatic. So if they're symptomatic, then you go into maybe what you do about it after that. And even if they have open growth plates still, a lot of times if you just immobilize them and rest them, that will resolve. The pain will resolve. So more for my criteria, particularly in the elbow, is if we have any mechanical symptoms along with being symptomatic, like catching, locking, that type of thing. That usually is from fragmentation of the cartilage, or when that may be just cartilage, or it may be cartilage and bone, depends on the size. A lot of times with this, you can put scope into the elbow and clean it up and do maybe a little microfracture. Sometimes if the lesion is big enough, you have to do plugs. So kind of just depends.
I know you spoke about Panner's disease. I know I just started working with middle school athletes, so a little bit younger of the crowd. How do you feel we can properly, kind of allude to that or figure out if it's that and if they need to be seen for that?
It's really the X-ray presentation and kind of the history. It's it can happen from an acute situation, or it can happen from just kind of repeated insults such as overuse. So again, paying attention to the pitch counts, paying attention to your kid, saying the elbow hurts, particularly on the lateral side, getting the X-ray when we need to, and that type of thing. So it's more just kind of make sure we stay on top of stuff, because if we leave it up to kids, they'll just play until they absolutely can't.
Do you typically see it in those older than 10, or does it usually stay within the 7 to 10?
So I only get those guys that don't read the textbook. So it can definitely present at older, type athletes with respect to physio issues. However, commonly it's probably around the 7, 10-ish kind of age group.
All right. So you talked about casting as an option for OCD or for Panner's?
Both.
For both, and that's just to limit them. And I mean, I know that recently we started putting kids in boots for ankle sprain, just because you immobilize them for a day or two, let it kind of calm down. And so I mean, I think it seems a little scary to cast them, but then at the same time, these are kids. I mean, I have a 3-year-old son, almost 4-year-old son, and getting him to not run or jump or tackle daddy would be impossible. So I mean, I think that's a really cool way to protect them.
Yeah.
And so that's good. And I look forward to learning more from you there. About the pitch counts, I know you said you got it from American Baseball Academy. Is that right? USA Baseball. So of course I could probably go back and look, but when it was saying, I think 8 to 10 years old was less than 50 pitches per game and 75 pitches per week, something along those lines. Is that including practice, or is that just per game?
Usually the criteria just for game, for pitches.
Mm-hmm.
And usually pitchers aren't practicing pitching per se in practice per se, So primarily those are game type counts versus say absolute throws. Again, there's a lot of sliding scales and recommendations out there. I typically use the kind of the most identified organization, which for baseball typically is the USA Baseball recommendations. Its advisory committee is all the names historically through sports medicine and that type of thing, Dr. Andrews and et cetera. So that way it's not coming from me.
Right.
Here it is. I highlight it and do as you will with the information. But certainly it's geared to protect the kids from kind of seeing a lot of these overuse type situations.
Now, I know that last year we had a JV kid, and every game I watched, he pitched or he was the catcher.
Mm-hmm.
Like, how bad is that? Because, I mean, you're throwing the ball every single play if you're a catcher or every single play if you're a pitcher. And so, I mean, how much does being the catcher on your off days affect?
I don't know if we actually know. No one has a crystal ball. But certainly, I think the bigger issue now that I see, and not just in baseball, but in every sport, is that there's no off season. The neuromuscular patterns for, say, baseball and, pitching are going to be different than maybe throwing a football. But because, prior to maybe the last 10, 15 years, you had everyone, good athletes played all sports.
Right.
You played football in the fall, you played basketball in the winter, and you transitioned in the spring to baseball or track or something like that. And summer you played everything, and then we played football again, all that kind of stuff.
Right.
Well, now you only play football. And you train, CrossFit or some sort of, sports performance type program in the off season for football, and then you play spring football, and in summertime you get ready for football, and you don't do a lot of other stuff.
Right.
I think that has produced a lot more of these overuse type injuries, where it used to be rare that you see maybe a Panners or something like that, but now kids for baseball, you have summer ball, you got winter ball or fall ball, then you got real season, which are high school or what have you. Then you got, all the other stuff that you're going to do with your, your club sports and all that kind of stuff. And then summer ball, it's just all year around doing the same thing. And I think that is where we see a lot more of the overuse type issues, and they're certainly becoming more common.
All right. So give us one big evaluation hint, tip, or what's your go-to, something that I can take away and really put into practice, obviously in August, but for evaluating the elbow injuries?
Really, like I said, it's prevention and early surveillance or having a high index of suspicion for injury. I think where we get out of link with some of the issues would be when you see a 15 or 16-year-old male and you're thinking, okay, they're throwing breaking pitches, they're doing all this stuff, and think that they can't have a FISO injury. Well, they can. And that's probably in the most common time when you're going to see a medial epicondyle avulsion fracture or something like that. So it's really probably a child less than 17, 18 years old with elbow pain. That's when we need to have a heightened level of suspicion for a FISO injury. However, that's the same time that we start seeing a lot of ligamentous injury too, and we're seeing that more and more commonly too. We get younger and younger kids requiring Tommy John type surgical approaches and that type of thing. So the biggest piece is not so much a test so much, but it's really kind of, you guys are on the front lines,
Right.
You guys see, and the kids too. So when they're hurt versus me, I'm pushing and I hurt. So it's the, throwing phase, when he had the pain, did it come on abruptly or did it come on gradually, where it is, and kids in the high school age range, I think we need to all have a high index of suspicion of possible FISO injury. And a lot of times the modalities that we're going to use to elucidate injury versus X-ray versus MRI will also help us with determination of that. And I think that's the bridge we all have to jump over. It's not so much unlike the knee where you can do this test for ACL, what have you, this and that. You can push here, you got, meniscus tear or something. The elbow is a little bit different in that, it's really about the mechanism of injury. It's really about, taking in all the information, like what part of the throwing did happen abruptly versus not abruptly, their age, obviously, and also, their gender. Certainly these things happen a little bit sooner in girls versus males. So, all those things kind of help paint the picture about what we need to do, where we need to go with it, versus just one big thing per se to do.
Okay, that's what I was afraid of.
Yeah.
It's not anything that's just all right. Well, this is something you can really do, but so like you said, you got to know the kid, know what they were doing, and if you're in any way suspicious, send them to a great orthopedic surgeon like you. So I know I've told you before, I really appreciate you allowing me to come out and come surgery because I feel like I learned a lot there. Even just the smell of the burning flesh that makes me queasy and I have to walk out for a minute. It's one of those things, and now I can explain that to students, and so I really appreciate everything you're doing for us and helping us, and then helping me grow as a professional. So
Hey, my pleasure, man. Anything I can do.
let's see, any last questions?
I did have one. Why do you think so many young athletes you see hypertrophy of the pronator muscles?
Mainly from what they do is their body's way of protecting them from the stresses. So as we talked about the torque involved in throwing motion, you should tear your UCL every time.
Mm-hmm.
You know, a lot of the throwing motions, if you measure the activity, if you measure the forces through the joint, you're seeing upwards of 60 plus newtons going through the elbow at any particular time, particularly in that late cocking as you're loading the spring versus the acceleration where you're letting it go. Now, also the violent part of that throwing motion is stopping your arm from going forward. So that's similarly as violent, so to speak. Okay, so the newer focuses from historically, it's all looked at the earlier phases of the throwing as far as prevention, chain theory, core, good strong core, scapular stabilization, scapation, cuff strength and all that kind of stuff, and grip strength too, pronator, flexor mass strength as well. The newer focuses are directed towards the deceleration phase, where you learn to keep, hold on to the ball, so to speak, to make the deceleration part of that throwing motion less violent. Okay, but specifically answer your question, it's more of just kind of what they're doing, and particularly as you get older, you're getting fancier with your pitches, you're getting a little more savvy with your speed and that type of thing, but you want to, have the ball breaking pitch away or what have you from a pitcher or from a hitter. I'm sorry, you're doing that with your flexor mass, that type of thing, to get the curve or the rotation on the ball. So that's your body's way of compensating for those violent time periods of high stress.
Right.
You need to make up about maybe half or double what your structure can actually withstand. So
Right.
UCLs in the lab at least tend to be around 30 or 40 newtons before they start tearing. If we're having moments where we have it was a 60, something else has to be taking the brunt, and that's the bony articulation. That's also the muscles around the elbow absorbing some of that force as well.
Right.
So that's a compensation for the things that they're doing. So not so much pathology as much as your body saying, hey, I'm being smart. You won't stop throwing. I got to beef up here to kind of protect us from, yourself.
All right, so last question, Trey. What are your big plans for you and your dad this summer?
Build big Lego sets.
Nice. What kind? What's
Star Wars.
Star Wars? Nice. We just got into building Legos, so my boy's been building some things, and he built a robot, a rescue hero. I don't know, but it was
That's what we're
pretty cool.
working on now, with the plan to get to where we're going to do next time.
Did the Death Star?
Yeah.
There you go.
Yeah, we got to save up for that one.
Yeah. I went to Toys R Us the other day. I was like, oh, we'll just play with all my old Legos. So, all right. Well, thanks a bunch for being on.
Hey, no problem.
Again, Jasmine's over there doing the production part, so I want to make sure we say hi to Jasmine. Jasmine Dozal. Thanks. All right. Thanks, Dr. Crumbly. Thanks,
Hey,
Leslie.
Thanks, guys. Yo. Cool.
Good seeing you again.
Likewise. Yo.
Jasmine.
Ready, man? You got keys?
You driving already, dude?
Got to put them to work, man.
No, you don't get any sleep. You got to drive for you.
I was going to ask if y'all saw the Lego movie.
Good? And took any pictures? Did you see any pictures?
Sorry.
Jasmine.
Do you want to listen to it? 'Cause it's so, to me, it doesn't sound as loud.
Well, I turned your headphones down
Okay, maybe that's why.
because I wanted this to be a little bit more. So this one's coming out. Just a little bit. All right, go ahead and talk.
Anyone?
Yeah, sure. Can you hear one of them, Jasmine?
Hello, hello, hello.
Hello, hello, hello.
Testing.
Check, 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 check. So it's showing that it's obviously it's working on here.
Yeah.
It's working on there. I can hear it.
Okay, just making sure. To me, this shit is not that loud.
You what?
It sounded a lot louder to me yesterday.
Yeah.
Oh yeah, I just set it up.
Close.
Who else is there?
File. Save project. Yes, who's next? Gordia. I'm gonna try and snap a picture with this if you can. Tweet the pictures out when you can. And then I can retweet them and whatnot. Here, let me put this. Let me see more. On the screen.
Just maybe pull down a little bit more.
Wait.
Yeah, a little bit to the left and a little bit down.
Good. All right, so remember you gotta just watch. I don't want the thing to come up and end the live stream.
Yeah.
So if you would just hang out here, I'm gonna go check and make sure that Michelle's doing okay there. So. Good? You need something to drink?
Yeah, I was gonna get some.
Okay, go ahead. I'll hang out here for a minute.
Sure.
Yeah, yeah. Because I think as long as somebody's talking or moving.
Okay.
All right, so next up we have ACL rehabilitation in the female athlete. You are seeing the legendary Bob Marley live right now. I just keep the live stream going up until lunch. So.
Okay, Dr. O'Brien will, he's going to have to leave as soon as he's done, so I've asked him to come early maybe
Okay.
to talk to the dentist. But he'll be the last one of the day too, so that
Okay.
if he's willing to do it, he'll come early. So
Awesome. All right, so we were talking ACL rehabilitation in the female athlete with Dr. Vipul Goradia. I believe that's how you say it. And so Bill and Steven should be doing that interview. Steven's another Memorial Hermann guy that has just either volunteered or been volunteered to step up and do some interviews. And so for all the help and support we're getting here from Memorial Hermann. And again, I'll always .org. All right, so make sure you just so you can see the screen in case that message pops up. It should say something like, "Are you still there?" Then you just click yes.
Okay.
Oh, they got the black cat thing up?
Yeah, he brought it back.
Huh?
He just brought it back.
Okay. I'll be right back. Sorry about that from where you were at that one. It's weird. I want to say Thomas on this side. You could try and pronounce this doctor's name.
Vipul.
Goro,
Yeah.
Gorodori. Gorodori.
Hello.
Yeah, that, and it's going to be tagged with recording this one live. Okay. Well, not live, but recording y'all's talks and then put it on a podcast. Oh, cool. For people that couldn't make it, and make this on CD. Okay, good deal. Cool. So.
Not much.
Got a seat right here.
Is this getting like filmed, video?
It's a live stream.
Really?
You can work with us?
I haven't tried to. I'm just gonna sit here, let you guys do the conversation.
Okay, welcome back, folks. This is Bill Hell, athletic trainer, Pasadena High School, and we're on the sports medicine broadcast with Dr. Garadia. Garadia. I knew I'd mess it up. But Dr. Garadia, you talked today about some new procedures in the ACL reconstruction. Was very interesting on some of the techniques and stuff. So could you just give us a little history for our viewers or people that are listening, your background and like where you went to school? You know, I know you work with Memorial Hermann because I looked your bio and all that.
Yeah.
Could you just...
Sure. So I went to medical school at the University of Oklahoma, and that's where I did my residency, and then a fellowship in sports medicine in Baltimore at the Union Memorial Sports Medicine Clinic. And I've been in practice for 15 years. 14 of those have been in Virginia, and just came here to Houston last August to join UT Orthopedics and Memorial Hermann.
Yeah, I noticed on your bio you said you work with some schools. So what part of the Houston area are you like working with? Like
Sure.
Dr. Crumby works with us in
Uh-huh.
the southeast side.
Yep.
You know, what schools and school district area are you working with?
I'm in the northeast area. We're working with Humble ISD, with Humble High School and Atascocita High School and Summer Creek High School, and then also Porter and New Caney High Schools.
That's cool. Okay, well, you were talking about a kind of a new procedure, and I was very intrigued in it. You know, I know the people listening can't see the videos as far as to the YouTube that you put on with the cadaver and everything, but could you just kind of go through and talk a little bit about, I know most athletic trainers that listen to this know about ACL reconstruction, but you were talking about a double bundling around the ligament, saving the ligament. I think that's what it was.
Yes,
Could you just kind of explain that? I know they couldn't see it on the
Sure.
video, but I wrote down the YouTube
Okay,
thing,
good.
so I'm going
Yeah,
to
you
give
can
it a
find
little
on
shout out on
YouTube,
that.
Absolutely. It's basically an ACL repair, so we're preserving the patient's own ACL. We're not taking it out. We're not putting in a new ACL. So we're going to preserve it. And this particularly can be done for those proximal tears when it just tears off of the femoral origin. And we suture it up and reattach it back to the femoral origin. And so that negates the need for a reconstruction, but it's a very new procedure. But I've probably done about 6 of these so far, and have had very good early results.
Okay. Well, you also talked about, I'm not a doctor, so I really don't understand some of this stuff, but you were talking about the PRP injections, kind of like mixing, kind of like stem cell in a way. Could you kind of elaborate on that? Because that's totally new to me.
Yeah, so the PRP is basically we draw the patient's blood, and this is done while they're asleep in the operating room, and then there's a special machine called a centrifuge that you put the blood in that spins it down, and as it does that, it separates the blood into a couple of different layers, and one of those layers has a lot of the platelets in it, and so we take that layer of the concentrated platelets and we can inject those. And the platelets have a lot of growth factors and healing factors in there, and so that can help with the healing response, basically.
So what are you looking for as far as that, the healing part? Is that like eliminating some of the later signs of arthritis, or?
Well, it's going to be mostly, getting that ACL to heal back to the bone. So we're trying to help that to heal back faster and better, and so that's what it can be used for. We do similar things in the shoulder for rotator cuffs. You could use them for tennis elbows, a lot of different uses for the PRP.
So we're still like researching, basically. So they're still doing a lot of research on this procedure.
Absolutely.
And I mean, I noticed you said you've only done 6, and you only got about 5 months of data on
Right.
yours.
Exactly.
And then you said there's some other doctors in the United States or in the area that are
Mhm.
using this procedure, which sounds like to me better than, I've seen ACL reconstructions, and I've seen how they take the patellar tendon graft off.
Right.
And if the patient saw it before they had it done, I don't think they'd get it done.
That's probably true. Yeah.
Because the smell, because you can smell it, and it's because when I saw one on one of our athletes, and it's like, you're banging on it, these fancy tools and everything
Right.
that they make, and they even have a technician who makes from the company that makes the tools is in the operating room with to make sure their tools and all their little fancy gadgets work. So I mean that's kind of intriguing as far as watching surgery, not being a doctor, but being in there with Dr. Crombie. It's our privilege with Memorial Hermann, and I just want to thank, not to take away right now, but to thank Memorial Hermann, because Memorial Hermann sponsors us, and they have the sign up with this podcast and with this update and everything. So we're kind of thankful that Memorial Hermann is allowing us to do this podcast here. And I'm kind of a rookie at this. So Jeremy Jackson is the guru at this, and he really started this whole podcast idea. And our shout out to U of H, Dr. Yellen and Dr. Knobloch, who couldn't be here today. They are back teaching with their master's program. They're kind of took this mostly yesterday, interviewed all the speakers and everything. So let's get back to your thing. Are you very confident that a new procedure might be the new standard, basically?
I think so.
That they're saving the ACL, and what kind of candidates usually are more for this? Do you think they're going to still use, like for your prime athletes, the patellar tendon because it supposedly is stronger? I mean, I know it causes what do you call it? The bleeding inside the knee and a lot of inflammation, pain and all that. So, kind of elaborate on hopefully that this new standard and the options that you said you discuss with your patients.
Right. Yeah. No, I discuss various reconstructions with patellar tendon and hamstrings and all of those things with the patients. That's really the gold standard. But right, you have to harvest those tendons. You got to take those tendons out of the patient, and it is a somewhat traumatic type of part of the procedure. We like to use the donor tissues when we can also, but a lot of the studies have shown that in the patients under 25, the allografts don't do very well. They don't have very good outcomes. They have a lot higher failure rates. And so I think the repair procedure is eventually going to become something that's widely used by more and more surgeons. They're going to find that it's much less invasive. The patients hopefully are going to do just as well, if not better, and they avoid having to have a patellar tendon or a hamstring taken out of their knee.
Yeah. So, I mean, we have a lot of ACL reconstructions with athletes in high school level. I've been an athletic trainer for over 30 years, and these last few years I've seen more ACLs than I've ever seen. What is the reason? Why are kids more susceptible to ACL tears at our new athletes? Is it because they're getting stronger, bigger, faster, and all that?
Yeah.
Or is it because of the way of society where the kids aren't as active? The majority of the athletes aren't as active. You have your elite few that are very, workout.
Right.
They're more, what am I trying to ask here? They're more likely to do their workouts, whereas the common athletes, the ones I deal with mostly, are the ones that, when I feel like working out, I'll work out, and I've seen more ACLs in females.
Right.
So
I think it's probably a combination of factors. Certainly in some of the contact sports, maybe it is some that are not as in shape as they should be, playing with others that are faster and stronger, that could be causing some of their tears. But in general, I think it's because there's just more exposure to sports. More and more, particularly in the females. Females are playing more sports now than they did 10 years ago or 20 years ago. There's more options for them. It's basically they have as many options as the males, and So I think that plays a big role in it. Certainly there's some question about whether some of the jumping and landing, the way that women do it with a little bit more valgus in their knees. I mean, certainly maybe some other anatomic predisposing factors for the female ACLs, but you're right, they seem to be increasing over time. I think it's a combination of those factors, just playing more and more exposure to the sports.
Okay, I got a question because I listened to Dr. Crumby, who spoke right before you, and he was talking about the elbow with the growth plates in the younger athletes. Now, would that have to do with the knee? Is there a chance with some of the ligaments in the knee with the growth plates at the younger ages where they're not necessarily getting diagnosed that they have like ACL tears or tears in their knee, where it could be not the ligament, it could be the
growth plate?
Yeah,
that definitely happens. We don't see it as much in the knee where they get a growth plate injury necessarily, but it certainly can happen in the younger athletes. We just don't see nearly as many of them. It's like, even a 13-year-old, you don't see a lot of 13-year-old ACLs.
I've seen 14 female.
Right, but it's just not that common, like it is the 16, 17-year-olds. So, but yes, the younger the child is, the more risk there is to injuring the growth plate because it is kind of the weaker segment, and that can fail before the ligament, just like he was talking about in the elbow. So that can certainly happen.
Yeah. Okay, I want to just give Jasmine's on that end down there with all this recording and everything. Jasmine, can you tie in and give out the Twitter account on this line so everybody knows what they can chime in on? Any questions if anybody happens to be listening? I don't know if we have any or not, but if they do, you can tell us. Jasmine's a college student at Texas A&M, one of our former athletes who's trying to pursue the athletic training profession.
Well, you can tweet using the hashtag the SMB for the sports medicine broadcast. If you have any questions, we'll be sure to ask them. So
Jasmine can let us know and we can ask.
Yeah. I just wanted to say I think it's fascinating, all the advances in medicine. I mean, 15 years ago, none of this was even an idea, an option, and everything's just really advanced and progressed to the level of what we're at, and it's really a testament to you and to a lot of the physicians that we have, that we have access to, especially in the greater Houston area. To have somebody like yourself, be a champion of this, I think it's really a testament, to you, and I really do commend you. And like you were saying earlier, I think the future of medicine is just, there's so many options out there that 5-10 years from now, we may not even think about this. There may be something else that's come up, and I think it's really fascinating, really cool to think about those options that we have that aren't even on the horizon yet. And this how it's going to advance to that level. I think it's really cool.
Yeah, no, I appreciate that, and it's definitely true. I mean, we didn't imagine this stuff just 10 years ago, and it's evolved so quickly that it's kind of exciting to think about what's going to be out there 5 or 10 years from now that we're not even thinking about right now.
Exactly. I mean, you're at ground zero right now. Because for everything going on in the future, it's really fascinating. That's Houston is such a great area for healthcare and for our medical center and just all the physicians we have, and to have that stuff that we're doing here in our backyard, and having access to doctors like yourself. It's really great, and I really, like I said, I really do, commend you for that and for that work. It's like I said, it just blows my mind to listen to all the doctors that we have. We have such a great team of healthcare providers here, just to get all their their expertise and information. It really just blows my mind. I know I'm not the only one who's saying that.
Yeah, go ahead and identify yourself so people are talking.
Yeah, Stephen Ramirez. I'm with Hermann, Sugarland.
Sugarland, yeah. Okay, it's going back. Go ahead and talk a little bit about I know this is a ligament that I knew it was a long time ago, but now it's coming back. They're talking about the anterior lateral ligament, how that is, and in my training and back in the old days, that wasn't even a ligament that was even discussed in the knee. So could you kind of talk a little bit about where is it, for people that don't know the terminology, like front, outside, you know.
Yeah, so I mean it's on the front outside of your knee, absolutely. You know, it is a ligament that
Did it
helps.
have another name, or was it always called the anterior lateral
I think
ligament?
when Dr. Houston described it, it was described as the um, lateral middle third capsular.
So it was basically more like a capsule.
It's like a
instead of-
capsular thickening in that area, you know, and that's where he first described it. And he was repairing those back when he was doing ligament surgery. And then as we shifted everything inside of the joint with the ACL reconstructions in the joint and arthroscopy and all of that, somehow that repair that he was doing got missed, and it, you know, it just wasn't exciting anymore to do that kind of surgery. Everybody wanted to do the fancy arthroscopic surgery, and just felt that, oh, well, that's the missing answer, is the arthroscopic. So we kind of, you know, the pendulum swung too far in one direction, and we kind of just forgot about some of those things or ignored them or whatever it might be. And so now the pendulum hopefully is getting back to a nice happy medium where we're like, okay, we need to do both, you know. We got to.
Can you still do that one orthoscopic?
No, you got to make an incision for that because it's not inside of the joint,
It's on the outside,
it's
yeah.
extra-articular. So you do have to make an incision. However, you know, the slides that I showed, you can make two very small incisions, you know, less than you know, about a half an inch in size. So it's not a big open procedure.
Okay. Because I think nearly every ACL that I have or have had in my athletes, they're all orthoscopic, except for I had this one this past year who went to a doctor who still did the old procedure where they did the old zipper, you know. I mean, but the kid is having unbelievable rehab. He was coming back just as fast as the orthoscopics. I mean, I'm not going to say anything about the doctor or anything because, you know, it's not my call to make that. I'm just the athletic trainer. I'm not the doctor of that athlete, you know, because he's still doing the same. He doesn't believe in braces either. And this is a basketball player as the athlete, but he's doing unbelievable as far as his rehab. You know, he's a little lazy, but as far as most athletes are, most teenage boys, they tend to be a little lazy and they get a little, you know, in that early rehab they get kind of bored and I want to do more. No, you got to be patient. But, you know, kind of talk about, I know rehab is more athlete based or patient based. It's not a, you know, when I'm trying to pull out, you know, make protocols for rehab and everything for athletes, you know, you tend to want to go to this set form. You know, and I mean, you can give them the old thing and say, okay, this is what I want you to do, and this is what I want you to do. I mean, when you're in a high school setting, it's really hard to personalize your rehabs when you have, like this past year, at one point, I had 6 ACLs at one time by myself doing rehab. I mean, because my assistant had a sports medicine class during that athletic period. So, I mean, it really kind of made it hard to do. I mean, we had, you know, 6 or 7, but I mean, when they were like in 2 different periods,
Right.
But athletic periods. But I mean, it makes it really hard to get on the kids because this one's, you know, at week this and this one's at week, you know. I know you had your phases, and I hope you're everything's going to be on Google Docs, you know, and everything later, because I want to get those, you know, different phases that you have as far as hopefully we might be able to get the videos, I don't know, but as far as how to do some of the different jumps and different things as far as that go. Kind of go through a little bit of the rehab, how you compared it to the military.
Right.
And then we kind of wrap this up because I know you have to get back to work.
I mean, I was kind of inspired with this rehab several years ago when I was teaching some courses with Dr. John Tokish, who's with the Air Force Academy as an orthopedic surgeon, and he showed these rehab programs that they do and kind of gave me a new perspective on ACL rehab and how hard they push the athletes and how meticulous they are with making sure that they complete one phase before just rushing on to the next phase. And the way he described it is, if you're a cadet at the Air Force Academy and you tear your ACL, if you don't get back to full level of function, and including their military drills and training that they have to do, and sports, which they're all required to participate in one sport, if they don't get back to all of that, they don't graduate. So it's not like you get a degree without having the physical part. It's all combined. You got to have physical and academic. And so it's a really big deal, and they have to make it that way because obviously that's how the military functions. And so it gave me a new perspective. For us, if we get an athlete that's not doing well or has had several revisions or problems, they just kind of stop playing their sport. And I mean, it's a big deal to them, but it's not like it affects every part of their life. So I started looking at this protocol, and it's a phase-based protocol, which a lot of us have used for a long time. But I like the way he broke them down, and you kind of start with the pre-op phase of getting their motion and everything going early on, and some quad function. I think if we get that quad function going early, they get less atrophy after surgery, which will help speed up the early phases. And those first 6 weeks, you're just kind of focusing on getting the swelling down, getting their range of motion back, really focusing on getting the knee out all the way straight. And then from there, once they've got minimal swelling and good motion, they're able to walk without crutches or anything, then we start the real rehab, and that begins with the static phase. So they're not doing jumping and all that yet. They're just doing static, strengthening a lot of leg squats, single leg squats. They may have to hold on to something initially, but then really focus on the good form, make sure that they've got good form at the very beginning so that as they progress, they keep that form. And if they can't get to the next exercise, they just have to keep doing this one until they can get there. And you go from the single leg squats to increased complexity. So you have them do it around a star, for example. Lunges at first and then around a star. Then you might go to an unstable platform. You get them one of those little blue soft platforms to do it on, and that's going to increase a whole different level of complexity. Well, then you get good at that. Now you got to stand on that and throw a ball back and forth, so that you're distracted, because these are all the types of things that you'd have to do when you return to playing sports. So the static phase, I think, takes the longest, but if you get that good foundation, then the next stage, the dynamic stage, where you're starting to do some of the jumping and landing, it's going to go better because you've built in some of that proprioception. And you start off just two-legged jumps. You're just going to jump with both legs, land with both legs. Then you jump with one leg, just jumping up and down in place, and they can wear their brace for this stuff too. And then you progress from there, and then finally get to kind of some sports-specific activities. The key is not to progress them until they're really ready.
Until they get the foundation right.
Yeah.
So yeah. So most people, I found in all the rehabs I've been doing, I mean, I don't do as many as the clinic setting does, because we send most of our kids, they use their insurance and everything. They go to the rehabs, at the clinics at Memorial Hermann, and then they come back to us during the school. So we basically do, we collaborate and do the things together. But basically, I've seen that I just tell them, you've got the first 4 months is it usually takes them about 4 months that I've seen. Every once in a while you'll get one that can do it a little before 4 months. The static is usually takes that long, close to 12 weeks.
Right.
So they want to know, so you give them an idea. So I basically tell them, so you might improve a little better than some. It depends on how hard you work, how much you put into it. But basically that's what I do with as far as rehabs. I do basically the same thing,
Right.
except I'm limited on what I have, so I have
Right.
to improvise. Kind of like
Well, and that's where I think we need to have better resources for y'all. If we can develop some of these videos and things, that way, you can show the kids, tell them, okay, you need to go in here and review these videos, and then go do it, and then,
Yeah, because it's kind of hard for especially me with my age and everything, and I'm not as physically fit as my assistant is, who's a lot younger. But as far as demonstrating them to these kids, I don't have the strength. I'm not a physical therapist. I'm not like some of the ones we had yesterday. They were on that's what they do.
Right.
In other words, they say, well, I'm not going to give a kid an exercise if I can't do it myself. So I mean, I don't have that time and that luxury, and I'm not going to take that time to get myself that physically fit to show these kids exactly what they're supposed to do. But videos do, so they actually can see it, makes it better.
Yeah, absolutely.
Okay, so we got anything, Jasmine? I didn't think so. Okay, well, it's been a pleasure to having you on our show or on
Absolutely.
this little talk here, little conversation. Thanks, Steve.
Yeah.
And say your name again.
Vic Garadia.
Garadia. Hey, I got to write that down.
There you
Dr.
go.
Garadia. And he's in the northeast side of the Houston area. And this is Bill Hell. And for Jasmine and the Sports Medicine broadcast, this is a wrap.
Cool.
Thank you, sir.
Yeah,
Appreciated it.
Yeah, no problem.
That's more talking than I've done, and a lot better than my Bubba interview yesterday was 6 minutes. Because
6 minutes.
well, I mean, he's just talking about that case study that he talked
Oh,
about. I mean,
yeah.
it's like, what else are you going to talk
What
about?
else are you
Oh,
talking
here you
about?
go, Dr. Grant. That's our Jeremy might want to. He might, because we have the podcast like during the school year, like once a week or whatever. I know Dr. Crumpy's been on a couple of times, but I'll talk to Jeremy about it.
Where will this be? Where will this be?
Oh, this will be on. It'll be on Google Docs, and it'll be on the card right there
On
where
that
you can look
website,
it up.
Sports Medicine Broadcast.
Yeah, on Sports Medicine Broadcast.
Okay.
But it'll take him a while to get these loaded back up.
You can download the podcast from iTunes also.
Oh,
on
okay.
iTunes.
Oh, that's cool.
So in other words, eventually he's going to have your whole. We recorded your whole lecture, and it's going to be put on. So what we did this broadcast, Jeremy did it. He started out as a little bitty thing you want to do. Environment and everything. And we pulled out classrooms. We did sports medicine because we're the sports medicine bunch. Now he's the tech whiz for GHATs, and we got GHATs to endorse it. And now I have the trainers from this podcast and see the news and different things, and we're trying to do other things. And we're kind of like partners now. We don't really know what to be partners about.
You sign my arm. Hey, sign my arm. They let me know autograph.
Because they were here yesterday and they have to teach you. They really love this and promote always some new things. Appreciate it, sir. Good luck. Good luck in your procedure. Okay.
All kids come to me to do it.
Just sign your back.
So no one in the line of the autographs.
Yeah, I want to read it because I didn't hear him talk because I was.
He went over there and like, there's a bunch of idiots. He kept saying, I know y'all know everything. As soon as I saw his college picture, I think, so yeah, that's right. And now it all makes sense. I know where I was.
College?
Well,
He went to
he
college.
was in the city where he was at college. No, I gotta show this that I was here. No, I gotta show you I was here. Certificate and where the draft is. Mike's, because of Mike, that's what I need.
I live in Sugar Land, same city as he does. Right, the same Walgreens. It's all good.
If it wasn't for Mike, I might still be working. Yeah. He did.
Jasmine, I sound better?
Yeah.
It helps when you have notes.
Yes,
I didn't have
it
notes with Bubba because I didn't even hear him talk. So it was like funny trying to talk to him and I didn't even have his notes or
Yeah,
anything,
like I
so-
wish I could be asking questions, but since I don't know what they're talking about over there, then I can't really ask them anything.
Well, if we had
Kinda
more
hard.
people here, then y'all could alternate
Yeah.
and you could actually run this and then go listen and then come back and do the one where
Yeah.
you
Just
actually listen
rotate.
to them. Because see, like when the doctors, this is theirs, blank. So you actually have to take notes, where some of them come prepared,
Yeah.
bring their slideshows and everything are already on here. You know, but if you don't listen to it, it's not the same as asking questions.
Yeah.
It's like yesterday, they were just, and they know exactly what they're talking about.
Yeah.
So they can just wing it. Dr. Yellen can wing it like, I don't know how he does it.
Well,
It's much better if you got notes, so you actually know what they talked about.
yeah. You want to sit in here on this one, or we can get Andrew, Steven or Leslie.
Do you know who's gonna be next?
I'll sit in. I don't know what he was talking about, so I'm gonna be like Stephen
Who's
was.
gonna be next?
I'll sit in so I can hear what the heck you talk about.
I am woman.
I am woman. Hear me roll. Mike Var.
V as in vindictive, A as in arrogant, R as in revengeful, and A as in.
So that means your spot is just dead now?
Yeah, what
End
they'll
of
do
the
is
day.
we may get out early tonight. So.
Yeah, get to fight the traffic more.
See?
Oh yeah, I love your.
That's what everybody said.
You
I
think
felt
you're a
bad.
doctor or something?
I felt bad because.
She goes sit in.
Oh yeah, I'm about to go to town with these questions, yeah.
I plead the fifth.
Tell me all about Natasha.
She's hot. She got to out you in there, need the law.
She's an escapee. Oh wait, I didn't get the drape from the last. Just have to take it off so people can see that.
Man, I was trying to get us out at 9:30 too.
You did a good job.
Test, test, test.
It is live right now.
Oh Jesus,
Test.
it's amazing.
I want to thank all those little people I crushed to get up
It
here.
is live. Streaming live for 4 hours, and then after lunch it'll be another 4 hours. So
Oh yeah.
Is it live or is it Memorex?
I have no idea what you're talking about. Is that like an old person joke?
They probably so.
Way old, yeah. See, Memorex used to be tape,
Yeah.
and you had to record. Anyway. Just like the phone.
Mhm.
So-
Yeah, we used to have those. I'm not that young. I
They
mean,
have landlines at schools, you know.
Hello.
kind of. It's like through the internet.
I want to say thank you to Alma Hermann.
Have you started the recording?
Maura Hermann
So it's
is,
not just
is the
live,
greatest organization on the planet.
Horrible.
They pay me twice a month, and I'm so grateful for everything.
You're missing out on some of your check.
They got me some shirts. They fit.
I hate you so much.
All right, so you have just heard the best of Mike Vara.
Thank you. Good morning.
All right, so I am Jeremy Jackson, and we are going to be talking with Mike Vara, athletic trainer. He's a self-proclaimed old fart.
Yes.
And
Yes.
so with the age comes
self-proclaimed.
lots of knowledge and opinions and a sometimes lack of filter. So just be prepared for that.
Yes.
Again, I have the lovely Leslie Humphreys here to help grill Mike
We
Vara.
emphasize the word lovely.
And so Mike was talking about knowing the new Senate bill, because here in Texas, the House bill, we have a state-regulated concussion management protocol.
Yes.
And just want to tell us do's and don'ts. Obviously, some of these things as athletic trainers are very, very simple. But before we get to all of that stuff, Mike, tell us a little bit more about who you are, where you came from, that kind of thing.
Well, I'm male. I'm 59 years young. I have a slight pigeon-toed, so my feet kind of hurt every now and then. I love walking in the rain. I love looking at sunsets. I was born and raised in San Antonio. I went to private school. The name of my high school was Holy Cross, so I'm a total loss from Holy Cross. I went to Southwest Texas State. I crammed 4 years of education into 5.5. I had to go an extra year because I had to modify my major. I took the wrong class my sophomore year, so here I am. It was the best thing that ever happened to me. I've had a lot of fun being an athletic trainer, and I was in San Antonio for 5 years at the start of my career, and then in 1984 I moved here and took a job at Woolridge High School, and it was the best thing that ever happened to me moving to this area. So I'm glad to be here, and I'm glad you people are getting to hear me speak.
So you just accidentally became an athletic trainer?
Yep, sure did. There was a mean old bitter woman at registration the spring of my sophomore year. Bitter woman, extremely bitter, probably going through menopause, and I would suspect that her husband was probably cheating on her, and rightly so. She was a bitter. I did say bitter, right?
Yes.
And I said, "Ma'am, I need a 3-hour class on Tuesdays and Thursdays." So she snatches this paper out of my hand, and back then there were something called computer cards for classes. I know you young folk are, tweeting and Twitters and all that. And anyway, so she gives me this class, and I thought, well, the class I was looking for was closed. Well, it turns out it was a care and management of sports injuries, which coaches were supposed to take. And when I show up for the class, it's the sports medicine class. So as I walked into the door, the teacher, Dr. Bobby Patton, says, "Where are you going?" That's how Dr. Patton talked. He talks like this. And I said, "Well, sir, I'm going here." He goes, "No, you're not." So I thought, well, okay. So anyway, long story short, for 4 weeks I sat in the back of the room. And then at the end of the 4th week, he told me to move up and talked about, athletic training. And so at the end of the course, I walked in his office and said, "Hey, Dr. Patton, how do you become an athletic trainer?" And whoop, here I am. So it's been a wonderful journey.
Thank you, Dr. Patton.
Yes, thank you, Dr. Patton.
Very interesting. All right, so one of the things that jumped out to me in your talk was you said know the law, make sure you read it and know it. So I've never read was it House Bill 82? Is it Bill 82?
Oh my God.
House Bill 5?
It's House Bill 2038, but
Yeah,
you were close.
Yeah, it was. I got the House Bill part.
You were close. Yeah.
So obviously I've never read it.
Mhm.
Right. So, as you said, you're an old fart. You came drops off papers. Why
Yes.
haven't you dropped off papers at our place?
Well, because Pasadena is supported by Memorial Hermann breakthroughs every day, and
Advancing health.
advancing breakthroughs every day. Just we'll split the difference. Because there's a colleague of mine that runs in that area, and I really just take care of the people in my area. But I love athletic trainers. I did say that earlier. Yes. I did tell you that I came in 1984. Yes. Anyway, House Bill 2038 mandates that a certain protocol is taken for concussions. And what I was telling the audience in there, all 6 of them that were listening, that it doesn't change anything that we do as an athletic trainer. I think it was more geared towards maybe coaches out there that don't have access to an athletic trainer, and what they did. And I think it's a good idea. I hate anything being mandated by law, like seat belts. I mean, I wear my seat belt because I don't want to go through the front windshield, but it's a law. You got to wear your seat belt. So like, okay. So now the way that we check for concussions and handle concussions and that sort of thing is now mandated by the state. And you know what a great job this Texas Senate does with laws.
So for trainers like you who go around, especially any trainer who has to work, say, a weekend activity, some kind of football camp, things like that, and you send somebody who might have a concussion, what papers or forms do you like, or information do you like to leave with their parents or that person taking care of them?
Well, number one, I always like the parent to be there when you do the evaluation, so you can kind of walk through what you're doing with them, and then you can always brush up on what the symptoms to look for post-concussive, because it's hard to say, well, we're going to hold you out and how you get home. Say, well, my mom comes for me, or my dad comes for me, or my stepdad, or my mom's lover, or whoever is going to pick you up. And so what happens is you're waiting there, you're looking to see if the kid's symptomatic, but it depends if it's a club sport. I mean, what do they do? What's their protocol? I mean, you're there as a healthcare provider. You're trying to say, look, this is the way it should be done. I suspect they got a concussion. You know, I don't know what kind of authority you have there other than thinking, well, let's keep the lawyers away from you. Let's take the best care that we can of this kid that we suspect is concussed. And a good majority of people will agree with you. They don't want to endanger a child, but you get the occasional, person that says, "Well, I think you're wrong," or "They'll be okay," or that's your call. But if it's a high school kid, we've got protocols. If it's a UIL or a charter school or private school, TAPS, one of those, I think everybody's on board. The concerns we have are people like club sports. I don't want to single out any sport, soccer, but we do have some problems with people out there maybe not really familiar with what we're trying to do with concussions. Soccer.
So you're a big fan of soccer.
Soccer is wonderful. Let me say that again. Soccer is wonderful.
I actually love soccer. It's my favorite high school sport.
Sorry to hear that.
Okay, so Bill and I, we work together in the training room. Obviously, we keep our files in the file cabinet. One of the things you were asking is, we need to know who has access to the files and that kind of thing. So who should be allowed to see the physical forms? Because it used to be the kids would get a physical handed to the coach, so obviously the coach had access, they could see it and that kind of thing, and then the coach would give it to us. Now we don't want the coach touching it just because then that makes the coach responsible. Now we want the kids to be responsible to hand it to us. So who should be allowed to look at a physical form?
Well, I think, and you're looking at any health care provider on campus. Obviously, the school nurse, the athletic trainers, the chain of custody of these forms is important because, if you have the right documents, you begin the return to play protocol, and then eventually you release the kid back to athletics. But I don't think it's a question of, put it on the bulletin board and say, okay, this kid was concussed, this is where he is right now. Obviously, you're trying to keep it out of the fewest hands as possible. We do have HIPAA laws that dictate who can see, medical information. And obviously, we're dealing with a kid who's concussed, so they've been to a doctor, so obviously they're in the medical loop. So the athletic trainers are the ones that I think should see it, who should be in charge of that, and they're obviously dictating their care because, according to the law, the athletic trainer is part of the concussion oversight team. So there you are. A coach can help you with the return to play protocol, but they cannot clear an athlete. So to answer your question, I think the athletic trainer or the school nurse should have first or second command of the forms. Obviously, if there's not an athletic trainer on campus, and there should be a coach who's in charge of injuries who should have that. It shouldn't be something that sits on a desk and everybody walks through, the Pepsi guy walks by and, hey, look at here, we're trying to keep things in perspective. So
Jasmine's taking pictures. Good job, Jasmine. Don't worry, she'll be tweeting it out later.
Tweeting.
She'll probably put hashtag grumpy old fart.
Excellent.
Definitely.
And that's a capital G. A G to the F.
And what part of the return to play protocol do you like to include coaches? Do you feel like they should be there right from the beginning?
Well, I like to keep them involved, sure. But I don't mind them doing the return to play protocol, because then they can actually see, yes, the kid is progressing. Yes, they feel better. No, they've had a setback, so we got to go back 24 hours and go back to the previous step that we were at before. And I think that just makes sense, because you're not in a combat situation with the coaches. It's not you versus them. You're not blaming anybody for that youngster getting a concussion. You want that kid to come back. That's what we do. I mean, that's our bread and butter. We get kids well, and let's roll, and let's go win, and that kind of thing. But if a coach walks in and says, "How are they doing?" You're like, "Well, they're doing better." Now we're a subjective term, whereas you take them into the weight room or the track or wherever those kids are doing their return to play protocol stages, then they can actually say, "You're right. He or she is progressing," or "No, they're not." So yeah, I like to keep the coaches in the loop, definitely. Soccer.
All right, so you talked about House Bill. What did you say? It was 5 again?
It's close. 2030 is.
All right, so again, I'll hopefully we'll go home and read it, over the summer.
Well, I've got a copy here. I can give you.
Do you? Good.
And if you'd like one, you can check my blog.
Is that the Texas State Senate blog?
Yes.
Or is that the memorial
That's funny.
on
I
the
used to think it
website?
was blog, like something was on your shirt. Hey, you got a blog on your shirt. I'm sorry. Never mind. Go ahead. Go ahead, Jim. I'm sorry.
I was just asking you where do we?
Where do I
we
wear
find
my
it?
shirts?
Yeah, where do you wear your shirts? No.
I wear them at work.
where was somebody else listening to this on the House Bill 2038?
Oh my God. Oh. You can find it, obviously, I found it on the Texas State Athletic Trainer Association website. They right on the lead page there, they have two places for it. They have Natasha's Law or HB 2038. Same thing, but I think people are more familiar when they say Natasha's Law. They're more familiar with that. So, but just Google it. For those of you that understand what Google means, Google. Yes, or Bing. I'm sorry, I don't want to look like I'm, showing a preference to anybody. Or Chrome. Is that the same thing?
Chrome
Bing?
is Google.
Chrome.
Google Chrome.
Chrome.
Bing is Microsoft.
All right, and that commercial brought to you by. I'm sorry. Go ahead.
I think I'm done with my questions.
Oh, okay. Well, are any callers? Caller on line number 1? No, nobody's there. Oh, 2, line 2.
Jasmine, you got any questions for? No.
Well, I want to thank you. I really enjoyed my time here. I hope I can be back one day. Not soon and not tomorrow, but
We'll think about it.
but yeah. But if you have a blog, let me know. And it's all good. I want to say hi to my family back in San Antonio. They're probably not listening to this, but I love you guys.
We'll make sure we send this to Holy Cross.
Total awesome Holy Cross. We were the Holy Cross Knights. I like that.
You repping Holy Cross?
It was an all-boys school, so part of my problem.
Well, thank you, Mr. Vara.
Oh, you're very welcome. Thank you for having me, and I appreciate this. A pretty cool thing that you guys are doing, and I hope people appreciate it. And as this goes off into space, I hope in a million years when the Martians pick it up and listen to it, they understand the importance of concussion management. And I'm out.
All right. Thanks.
Oh no, thank you. I'd like 5 copies of that, please. You don't mind?
So was that profanity I heard commercial out of it?
Hey, dogs.
It still is live.
Hey, dogs. I want to say hi to my peeps in California. Hey, you're up for parole soon, Dad.
Should have given a shout out to Kevin Bastin.
Where did you watch KB?
He's in Detroit.
Yes, he is. We miss him.
Have you hired anybody yet?
Yeah, they hired some slapping. They didn't want to hire me. That's right. So guys started mid-July. So we'll just keep going and do our thing and keep rolling. So, thank you, Jeremy. Thank you, Miss.
All right, so Johnson should be next. Your viewers,
Yeah.
All right, so next up we have Ron Johnson. He's a physical therapist, athletic trainer, licensed athletic trainer, certified athletic trainer, and CSCS, certified strength and conditioning specialist.
Dr. Rivers is going to have to leave as soon as he's done with his breakouts. You want to do Dr. Rivers now?
Sure. What are we talking about? Overuse, injuries, and knee. Is there somebody else that can come in and help?
Yeah, Mike will help.
Mike, you want to interview Dr. Rivers?
Really? This is going to go downhill fast.
Yeah, we just did Mike's. It was interesting.
Okay.
It'll actually be the other one open. Yeah, Rivers. All right, so we have Dr. Rivers coming in. He's gonna have to leave right after his talk, so we're gonna do his interview beforehand. Is gonna be overuse injuries of the knee. Typically, what we do is follow up on your talk.
Okay.
And ask you to kind of expand some more.
Okay, because I can't really remember what I'm talking about.
Overuse injuries of the knee. So.
Okay, cool. Thanks.
So you might have to just give us a preview here. This is Jasmine Dodal. She's one of my former students.
How are you?
Nice to meet you.
Steven, you can sit in here if you want.
That's good. No.
Okay.
I got one jackass in here. I don't need two.
It is,
there's
it
two.
is streaming live.
Is it? Okay.
But Mike was just on here, so you know the quality of this just went down.
Yeah.
So.
Yeah, I'm glad I'm falling right in line behind Mikey V.
I want to say hi to all my peeps.
Who's actually
Yes, I'm back.
Your
This
peeps aren't listening.
is going out to space, so like Voyager 1 left the universe, so will our conversation. So, all right, Dr. Rivers, welcome to the show. We've got all the hits for you today. We'll be spinning some. Oh, I'm sorry. Dr. Rivers, what is your talk today?
Overuse injuries of the knee.
Why did you want to pick overuse? Do you think that Americans overuse their knees?
Well, if you look at the weight they put on them, in a lot of cases that's true. Actually, I didn't pick the topic. I think it was kind of picked for me, honestly.
Excellent, excellent. So now we're making fun of obese people. Okay. So What's the biggest concern you have for an overuse? What's the biggest problem you see for overuse knees?
Well, I think the hardest part is really deciding when they're legit and when they're, just whining, wanting to get out of stuff, that kind of stuff. That's the tough part. And sometimes it is, overuse stuff does hurt and it does limit people. And so I think that's the hardest part is really finding out, who has a legitimate complaint and who's just kind of.
So what anatomical problems do they present?
So probably one of the more common things we see, especially if we're looking at the athletic population, is patellar tendonitis or jumper's knee. Younger population, your adolescents, early teens, you can see Osgood Slaughter's, basically almost a variant of the same thing. Still involves the extensor mechanism. We can see osteochondritis dissecans lesions. We can see in your cross-country kids, you can see, and track athletes, you can see IT band syndrome, patellofemoral pain. So runs a pretty good spectrum.
And all these are non-surgical conditions, correct?
Typically. In most cases, yes.
All right, so you mentioned IT band syndrome. Is it normal for a 11, 12-year-old athlete to have chronic IT band syndrome?
That would be a little unusual. It depends on really what activities they're doing, but a lot of times it's your long distance runners, people running, cross country is a big one, run on uneven surfaces, that kind of thing. But you do have to look at other issues. Sometimes they have anatomic issues with their feet, which kind of predispose them. People with high arches, flat feet, and malalignment of the foot can have issues as well. It's a little unusual in somebody that young, but it can happen.
She was a club volleyball player. And I was like, she had been diagnosed with chronic IT band syndrome. I'm like, all right, I would take a break.
If it was after, I guess, the history would come into that, I'd have to look at, really, did you have an injury? Did you have a fall in the that kind of thing? I mean, certainly you can get, a contusion, a fall in the knee, and you can get a post-traumatic, tendonitis, which is a little different than an IT band syndrome, which is more of an overuse thing. So, it all come down to history in that one. I haven't seen an 11-year-old. We see lots of them. We'll start seeing a lot of them this fall as people start training for the marathon. They pick way up.
Yeah.
All these people that are trying to get ready and that kind of thing. And most of the time we can get them through it. They can start running everything, so it doesn't limit them too much.
You'd mentioned Osgood Slaughter's. Could you kind of explain what that is?
Oh yeah, I'm just glad you didn't ask me to spell it.
Has an O in it.
It has an O. There you go. It has two.
Starts with an O.
Actually 3, doesn't it?
Excellent.
But
yes.
2 just together. There you go. So Osgood Slaughter's is basically the apophysis is a growth center that doesn't add to length of the bones. That's different than an epiphysis, which is where the bones lengthen. So an apophysis is a growth center. On the front of the knee, you've got the tibial apophysis, which is that gives you the bump of the knee, the tibial tubercle. Well, that's the tendon attachment site for the patellar tendon that runs from the kneecap down to the tibia in the whole extensor mechanism. So in young kids or in rapid growth activity, that kind of thing, they can get basically an inflammatory reaction within that growth center. They'll come in with typically it's classic, they'll come in, early teens, swelling, pain right on the front of the knee, usually a knot. So it's, usually you look at them and you don't even have to, you look at age and you look at their knee and you don't have to do anything else.
And they tend to grow out of that particular condition?
I mean, it's rate limiting, so eventually they will grow out of it, but it can be pretty uncomfortable and worrisome, particularly to the parents while they're in that phase. But what you do is ice, anti-inflammatory medication, stretching, some rest. There's a lot of different things you can do.
I know in some younger football players, we would actually do a donut pad on that particular injury.
Right.
And then it would seem to help. But other kids, like the basketball kids, volleyball youngsters, they just stretch, ice, anti-inflammatories, and they kind of move on.
And that's kind of the common thing with with the majority of the overuse stuff. Unless you get into, by nature, overuse means it's overused. So you underuse it and it gets better. So that means a lot of these things need rest. They need time off.
Well, yeah, that brings my next point about kids that are year-round sports now, or a year-round sport, I should say. You'd mentioned a volleyball. Well, kids go through a volleyball season with their school, and then they play club, and then they play select, and blah, blah, blah. So when you tell them as a physician you need to rest, typically what's their answer?
I've got a tournament this weekend in Dallas. I've got a tournament next week in Florida. I've got a tournament the next weekend in San Antonio.
Yeah.
So that's the typical response. They don't want to rest. They don't want to stop. They don't want to hurt, but they don't really want to stop either. And so you just kind of have to, in that case, you have to give them realistic expectation, control the symptoms as best you can, and work with that. Sometimes the parents are completely unreasonable. That's fine. That's their prerogative as parents. But most of the time they come in, it's been going on for a while. It doesn't really limit them too much. They just complain of pain, so they're able to play through it. And that's fine. I mean, we basically give them some things they can work on. It could help manage the symptoms and make it a little bit better. And as long as they know they're not doing harm to themselves, then they're okay with that.
Can you give a little bit more insight into the treatment of their symptoms? Like you mentioned ice. Is there a particular routine that they should develop when they ice?
Big thing, I'm a big proponent of ice massage. So take you some Dixie cups or coffee cups, fill them with water, throw them in the freezer, take it out, tear some paper off, and just massage that area that's swollen and tender right with that big ice cube. Because I think it works better than just a bag of frozen peas on the front of the knee. Because I think it's more focused. So that's kind of what I try to get people to do.
What about over-the-counter medications?
Yeah, Motrin, ibuprofen, Aleve, those kind of things. We do a lot. If somebody's real bad, then certainly we could do prescription medications. But I think most of your over-the-counter stuff is going to work just as well.
And
be a lot cheaper.
What's the length of use for that? If they're using something over-the-counter,
it depends on the symptoms. A lot of times I think you really need 3 to 4 weeks for most things. What happens a lot of times is they'll take them for 10 days, they'll start feeling better, and then they'll quit. But then they go back to activity and things start coming back again. Yeah. So I try to explain to people you kind of need to treat past the point where you start feeling better, because certainly it's settled down. But as soon as you go back, if it's not quite completely recovered, you're going to irritate it again. So I think you kind of go past that point. The same thing with stretching and that. I mean, you don't just stop when you feel better. I think the stretching and those kind of things with this. A lot of these overused things, stuff you need to keep doing on at least a reasonable basis. You don't have to do them every day, but a few days a week can certainly contribute to staying healthy.
So you try to find a healthy balance between their sport activity and maybe just trying to tone down what they're doing.
We can. I guess nodding doesn't come across on it.
Oh no, there's the
really?
camera right there.
Oh
yeah.
God. Dang, I thought we were just
yes, sir. Hey, welcome.
Hey, hi, Mom. Yeah. So, whatever the question was, yes.
But the thing about we'll go. I don't mean to pick on a volleyball player, but they seem to be the ones that have the most problems. Would you agree to that?
Well, I think they're prone to a lot of problems. First of all, teenage girls are more prone to anterior knee pain or patellofemoral pain, and then volleyball and lots of jumping, so they're more apt to get patellar tendonitis. And then they're diving on their knees, so they're they're still traumatizing the tibial tubercle and the patella and all that, just the repetitive trauma pounding on the knee. So they're kind of at risk for a lot of these things. A lot of these things involve the extensor mechanism, so they're definitely one of the big, I don't want to say offenders, but somebody you see a lot of those in.
Mm-hmm.
Do you think that, like we were talking to Dr. Crumby earlier, and he was saying the mechanics of throwing a football are different than throwing a baseball, because he was talking about elbow injuries. And do you think just because of the specialization and the year-round thing is the reason that most of these kids are having overuse pain, or is it something that even if a kid plays football and then basketball and then track, is he still likely to have that?
I mean, they can. They certainly can. I mean, certain overuse injuries, but I think that mixing up sports is crucial. It keeps you from just overusing one body part, because if you, like I said, football, basketball, baseball, you're using different body parts in different manners. So it's, even though you may still be very active, you're changing the mechanics enough that it allows some things to rest. So I think I'm a big proponent of, you got to do more than one sport. You can't just throw baseball 365 days a year.
Right.
Unless you just want to burn yourself out and wear yourself out, and they come in, well, I don't know why I hurt.
Yep.
Really?
Mm-hmm. Yep.
To sound old, and say back when I was a kid.
Yep.
We didn't have all that kind of stuff. We played a little summer league basketball, and we played basketball, but that was it. When football season rolled around, you played football. So
yeah, especially with mom and dad in the room, and they're paying all this money for them to be on these teams
and private coaches and everything.
You're telling me that they got to rest for 4 weeks? Yeah.
Right. And their coaches and their kids are retirement plan.
Yep.
They're going to make it big, and mom and daddy are going to live off the kid.
All right. So what are some of the evaluations you do for anterior knee pain?
There's a whole laundry list of things you can do. The big thing is just location and tenderness. First of all, I mean, you look at the knee, check for any swelling. You look at the tibial tubercle, patellar tendon, you palpate things. That'll tell you a lot right there. And again, history too, age, sex, those kind of things can play into it. So you get a lot of information before you actually really touch the patient.
Mm-hmm.
And then, as far as you want to examine the patellofemoral joint, you want to, have an idea how the patella tracks just by having them flex and extend the knees and make sure they don't have a big maltracking problem like the old J sign with the patella where it pops to the side. So there's a lot of things like that. And then, a lot of the overused stuff is it's location of the pain, tenderness, and history. Now, the things you can do, you can certainly, stress fractures are an overuse phenomenon. Osteochondritis dissecans is an overuse phenomenon. Those are going to be a little bit less specific, and you're going to need to do x-rays or something like that to find those. But the biggest thing is really just the history and just putting hands on them and seeing where they hurt. Not too complicated.
All right. So I get a couple of kids a year, and they'll tell me, it hurts on like just outside of my patella. So it's not, I guess, distal of the patella, but it's on the lateral side of the patella. But I guess no, they don't hurt with the meniscus test, those kind of things.
Right.
So I know that I've heard it say like the plica or the fat pad there, but
And then you can get, certainly the fat pad is really below, it's kind of behind the patellar tendon, so just below the kneecap. And you can get actually what they call Hoffa's fat pad syndrome, or Hoffa syndrome, which is you basically have usually it's an injury, it's a fall, or it's a force to the front of the knee, and they get a little inflammation in that fat pad, but it's usually right in the front of the knee, below the kneecap. Now, if you start getting a plica, classically is on the medial side of the knee, and then on the outside, a lot of times it could be just patellofemoral pain, either due to maltracking, if they're tracking a little bit laterally, or they get a little bit of lateral, overload. They can get some of that pain around the lateral side of the knee. So, and those kind of things, it's really, stretching, mobilizing the patella, keeping their VMO strong, keep that patella where it needs to be. Unless there is some mechanical malalignment problem, they've got a big Q angle, they're really knock-kneed, that kind of thing, and there's a really more of an anatomic issue. And then that gets into a whole other spectrum of treatment issues.
All right, so I was only on Twitter for a few minutes last night, and I saw somebody post something, and this is really bad because I don't know who posted it, and I didn't read the full article, but it was saying that typically we'll do a quad set to isolate the VMO to really get that last, and that was saying that studies have shown that there is no test to isolate a single muscle of the quad, that they all work together. Have you heard that?
I haven't heard that. And of course, I'm not a big literature guy, and I'm definitely not a Twitter guy. But so I think there is some truth to that. Certain exercises will work. The quads all work together, and so different exercises in different exercises in different range can certainly maybe not necessarily isolate one particular part of the quads, but they can put emphasis on that particular part of the quads. But I think certainly you're working, if you're doing quad sets, you're working the whole quad. But I think you can emphasize certain parts.
All right, so and then recently we talked to a guy, his name is Josh Stone, and he said that when he went with one of the teams over to Europe, I think it was Europe, it was a foreign country, they didn't use ice at all for treatment. And you said you're a big proponent of ice massage. So, kind of his point was that using the manual therapy, so the movement, the exercises, those things are far better than ice, and a lot of times we ice just because that's what somebody else told us and we don't even know why. What are your...
Well, I think, they all work together. I wouldn't say, fortunately we don't have to pick one thing to go with. I think if you just had to say, okay, I can only do this one thing, and I think what he's saying is true. But I think ice in relation, in association with the other things, they all work together. So I think there's a synergistic effect by using everything.
But I think people are more comfortable with ice.
That's because ice, it's easy.
Yeah,
it's hot, put ice on it.
Yep.
It's hot, cool it down.
Yep.
It kind of makes sense. So, and of course, for decades now, people go to therapy, they do the therapy session, what they do when they get done? You put ice on it.
Down, that's right.
You got a boo-boo, what do? You put ice on it. Your ankle sprain, it's ice. It's not whatever it'd be, I guess, RCE without the I, but, it'd be kind of...
Remember, there's no I in team. I thought I
There
just
is a
mentioned
me.
that.
Yeah, so we
For all you
actually
trivia fans.
had like a back and forth conversation between Steve Kennelly, which is an athletic trainer for the New York Giants, and then Josh Stone. And Steve was kind of like what you're saying is, ice is good to use for the mental aspect and to help reduce the pain right now so that we can have a long-term healing effect. So, it may reduce the healing right now, but then give us a long-term healing effect. So.
What ice does, it helps with the acute inflammatory response. Basically that's what ice is trying to do by causing, what you're doing with ice is you're causing, constriction of the small vessels, you decrease the bleeding. So if you have a hamstring injury, we don't put heat on it right away because he's going to cause those vessels to dilate, you're going to bleed more, you're going to bruise more, you're going to swell more. You put ice on it, you cause constriction of those small blood vessels, and you decrease a lot of that inflammatory response and the swelling because, you constrict the vessels, less blood flow gets there, less of those inflammatory mediators get there, and those kind of things. So, that's the principle behind ice.
Okay, so your talk today is about overuse knee injuries. So as an athletic trainer, how am I practically going to use, obviously you haven't given your talk yet, and apparently you aren't 100% sure what your talk is.
Yeah, I know it is. I haven't looked at it since I sent it to Bob a couple weeks ago, though.
And so what's some practical take-home steps for me or any of the athletic trainers that listen to this later?
I think the big thing is you got to, you see a lot of kids that come in and say, well, did you go talk to your trainer at school, your athletic trainer at school? And I said, yes. I said, what do they do? Tell me to put ice on it. Well, certainly, I think, being an athletic trainer around kids all the time. So I think y'all are in a unique position to be able to know the kids and really know, okay, is this a kid who's in here all the time with some bump or bruise or ache or pain? Are they here all the time? Or is this somebody who never complains of anything? So I think that, first of all, y'all know the kids. So if they come in and it's somebody, that isn't behaving the way they normally do, then, your antenna go up that, okay, this may, the treatment of all these is very, it's rest, it's, a lot of times the bracing, it's the, massage, the ultrasound, it's all the things that you have at your disposal. I think the biggest thing is really just kind of listening to them and seeing, knowing what fits with what, population. Fortunately, this is not a super complicated area. Usually where they hurt is where it is, because there are only so many things that can hurt in a certain spot.
Right.
And if they're not getting better, then, okay, maybe there's something more. If you're treating them for, Osgood slaughters or patellar tendonitis or something like that, they're not getting better. Well, then you start thinking, okay, what else is it? Could it be a stress fracture? I've seen plenty of people that I treated for hamstring tendonitis or the insertional tendonitis on the tibia or whatever it is. They weren't getting better. After a few weeks, they come back. We get a X-ray's normal, but they're hurting. They're right there. They're not getting better. We get an MRI, and certainly they got a stress fracture. So it changes the dynamics. And so it's really just about you do the appropriate things, and if they don't get better, well, then you escalate it and you start thinking, okay, what else could it be? Fortunately, there's only so much that can happen in a small space. And this isn't that the thing about the overuse stuff is it's not nearly as exciting as an ACL tear or a fracture, patellar tendon rupture. Those are cool. Those are obvious. They're nasty. They swell up. They can't walk. Those are fun. Those are cool. These are kind of a pain in the butt, honestly. It's like these are the ones they come and say, okay, what? Did you have an injury? No, it's just been hurting for 3 months. Yeah. You become less interested, I think, a lot of times because it's not as cool. And I say that too.
Yeah.
It's not as cool in my office either.
Yeah, it's just,
you're training.
It's just real hard to identify what the problem is because it's been hurting them for a couple months. So then other things begin to hurt, and it's just not a specific area.
Yeah, and those are the ones that are tough. The ones that don't have, they can't pinpoint their pain. You ask them where they hurt, and they put their whole hand on the knee.
Yeah.
Okay, point with one finger, and they'll give you, they'll draw a big circle. And that's not really the point. So some of them are tough to really kind of pinpoint and figure out exactly what it is. But I think really the sex, the age, the history, those can help direct you, a lot, and then further narrow it with where they hurt.
All right. Mike, this was his first time starting an interview, so he didn't actually introduce you and kind of give you a chance to tell you to say who you are. He knows. Yeah. And so, why don't you tell me just for a minute who you are, where you're from, that kind of thing.
All right. Tom Rivers, orthopedic surgeon, Richmond Bone and Joint out in Sugarland and Richmond. Unless you want to know.
How long have you been at Richmond Bone and Joint?
Since 2003, 11 years.
So I worked in Fort Bend. I worked at Fort Bend Bush. I used to go to quite a few of the CEU athletic
Yeah.
trainer things that they had there. I don't know if I met you.
Yeah, I don't know if we were
I know there was a Dr. Kent, is that right?
Yeah.
There's a Dr. Kent out there and a
Yeah, usually
Dr.
they try
Lang.
yeah, Liang. They usually don't poach all of us because
Yeah.
somebody's got to work to pay the bills. Somebody's got to see patients, so they try not to poach all of us to do those. But yeah, I mean, we've done a few of these here and there and that kind of thing.
And so I know you were at the GHATS. Didn't you help the GHATS Hall of Honor celebration? Were you there?
I was not there for that. I was not.
They mentioned you though.
Oh, did they?
Did you?
Maybe I gave them money or something. I don't know. That's probably why.
All right, so you did something with GHATS. I remember they mentioned Dr.
I was supposed to
Rivers.
be there, but I couldn't get back in town quick enough.
All right, so that's how you know Mike. He works in
together.
that same
Yeah,
office.
he's worked with us.
Gotcha.
I got to know him a little bit when he was at Seven Lakes, and then, as he went to work for Herman, and then came to work for us, and then went back to work for Herman as we became Herman, and it's been a winding trail.
Okay. Well, any other thoughts on anterior knee pains, Memorial Hermann, sports medicine, any of that stuff?
My mind is completely empty right now.
All right. Well, Dr. Evers, thanks for joining us on the sports medicine broadcast.
You bet. Oh, that wasn't too painful.
All right, so next up we should have Ron Johnson or Dr. Candace Tunis. I'm not quite sure. But we are here live at the Memorial Hermann Sports Medicine Update. Looks like we got Ron Johnson walking in now. Bubba, you joining us?
Yeah, I'm going to help interview Ron.
All right.
Where do you want me?
Either one of those two, and then Ron will sit there at the head of the table.
Holy cow.
What's your dad doing?
I think he's heading to Omaha right now.
Is he?
Yeah, he was regional director at the Rice tournament.
Okay.
So he kind of got himself in that. Then he's always got his board meetings and stuff. And then go to Omaha.
You got it. It is recording now, and obviously it continues to be live until after lunch. So.
Okay.
Okay, welcome back to the Sports Medicine broadcast. I'm Bill Hell, athletic trainer at Pasadena High School. With me is Bubba Wilson, renowned specialist from Memorial Hermann, and we have athletic trainer Ron Johnson with a lot of letters behind his name there. Ron, can you, before we get start talking about in-season shoulder conditioning that you just got through talking about, can you give us a little history on you and all those titles?
Well, I don't know what all those titles really mean. I like to tell, here's the truth in the patient world is people don't care how much you know. They just want to know how much you care. So they don't, it ends up being meaningless to them. So it's fun working with patients. I guess my background is as a baseball player. I grew up with my dad as being a college baseball coach. I played college baseball, so it was kind of fun for me. I started my first job, and the way they had it kind of delineated at the clinic is it was a sports medicine place, and you were either shoulder guy, knee guy, foot and ankle guy. And the first day I showed up, I was told I was going to be the shoulder guy. So that's kind of how it ended up being. And then I kind of had fun working in the baseball world, and kind of found a little niche in therapy and athletic training with the baseball folks.
Let me guess who told you were going to be the shoulder guy. I know exactly who it is.
So,
well, you were talking about in-season baseball conditioning, and you talked a little bit about off-season. First, the importance of the strength training and preseason screening. Can you kind of talk a little bit about that?
Right, so kind of what goes on in season is kind of all for naught. We're fighting an uphill battle unless we've done something to prepare ourselves for in season. So, the evidence is out there saying if we have significant loss of interrotation in the shoulder, we have loss of horizontal adduction, we have weakness in the shoulder, that has been proven to be possible deleterious or leading up to injury. So we catch those guys in the off season, we could do something to remedy it, and then all of a sudden we're lessening their chance of having injury in the season. So I think it's huge that we do something prior to the season and not wait till we already have problems in season.
Hey, Ron, you and I have known each other a long time, and this is kind of our combined passion of this stuff right here. We've talked about a lot of different things over the years. Have they looked at, and I'm sure have they looked at anything with just elbow extension and any loss of that? Does that play a part at all? I mean, I know some of it's adaptive in nature from throwing, but if you lose a significant amount of that, does that change anything?
No, actually doing my research and background checks on the talk, there was only one study out there and said actually no. So they didn't come up with any deleterious effect of you having loss of motion in the elbow. Loss of shoulder motion and even loss of hip motion has led to even elbow problems, but the elbow itself, not really.
Really, it's almost an extra stabilizer in a way for.
Right.
So yeah, okay.
Okay, well, that's interesting. I could just listen to Bubba talking because Bubba's talks about baseball more than I do. I mean, baseball was key, but I didn't play baseball. So, just looking at my notes here, you were talking about. It's a lot of this you can go and listen to. You reiterated about making sure the core is very a high point, and I keep stressing that with the baseball players and all athletes about their core. Can you talk about the importance of the core in relation to, like you talked about, the internal rotation of the hip and how the explosion or how the hip explodes, how the hip ties in with the core?
Yeah, that's a good point. So I think, 20 years ago, baseball players, we just looked at the shoulder and the elbow. Then we had this revolutionary idea that the rest of the body matters too. So the core is kind of all-encompassing. Depends on who you talk to. Some people say that's just the abdominal stuff, but we're talking about here, that includes all the scapular stabilizers and what's going on in the hip and trunk. And so if the hip and trunk's not mobile enough, if our trunk's not stable enough, then there's no way that the forces can properly be transferred to the rest of the body, and it's left with putting over stresses on the shoulder and elbow. So some of their mechanic faults very likely are mobility, flexibility, strength issues, and the poor fellow can't get things right just because he doesn't have the ability to get it right, not because his coach is teaching him wrong or he's not trying hard. So maybe we can pick up some of those physical needs and help him out.
So therefore, athletic trainers, we should really stress towards the baseball coaches the importance of the whole body.
Right.
Every coach, every sport.
Yeah, every sport.
Yeah, I think coaches are clued in on that right now, and I meant to mention all this, but the good news now is that coaches know this stuff. And the baseball coaches, they go to the conferences and courses, and they hear everywhere they go, there's at least one or two people that kind of give a medical side, strength and conditioning side of it, so they know it. But their problem is going back and implementing it. They go back and they got a million things to do, and far down the list is trying to do a little bit of a baseball screening or something. So us as athletic trainers on the spot, they would love for us to help them out on it. I think if we, more than what we realize, if we approached the baseball coach and said, hey, I would love to help you out on this, there's some things we could do, they would say, that's great. I know we need it, but I've just never been able to implement it myself. So I think they'd be more than happy to, more times than not, to let us help them in these cases.
Yeah, I mean, that would be great. Sometimes being an athletic trainer in a high school, all-season baseball is in the middle of the most important sport in the state of Texas, which is football season, and it really makes it tough to do those screenings, like you said. But
I think sometimes it's, well, we don't do a full team screening, but those guys, everybody knows who those baseball guys are, and whose parents love baseball, and the players are looking forward to baseball, so you probably can get some screening done on at least a handful of those guys.
Yeah, and at least work with some of the off-season,
yeah.
the off-season the baseballers that are not. And then I know my baseballers that are football players also.
Yeah.
Usually, like your star quarterback is also
your shortstop or
your
pitcher.
Or,
and then we see it too. They play a football game on Friday, and they go on the baseball tournament on Saturday, Sunday, or some type of showcase.
And they're working fall ball and stuff.
Wow.
And
yeah.
Select teams and all that. But I mean, I like the ideas of some of the things you talked about. As far as one thing I didn't get, I couldn't see the screen well. Was you talking about the GERD and the adduction part? I mean, I just couldn't see the screen with all the statistics you were throwing up there. Can you kind of...
Yeah, so on the screening, on the GERD, which stands for glenohumeral interrotation deficit, so we know it's normal for a baseball player to have loss of interrotation compared to his non-thrown side. So that's just a given. And some of that happens, it really boils down to the bony adaptations, but what's the window? So if they have a greater than 13-degree loss, then that's kind of a red flag to saying, ooh, we need to do something about that guy. And so that should be on the list of remedying his interrotation deficit. And part of the good news too is a very safe to be able to work on interrotation stretches. So very rarely are we going to have a guy who's hypermobile interrotation and posterior capsule-wise that was a danger. So most all baseball players could benefit from stretching and interrotation. And horizontal adduction is probably one thing I hadn't got enough play lately, and to include that cross-body stretching on the stretching program, because that helps remedy the GERD as well.
Yeah, because I want to see your stretches in the breakout on some of those, because I had some old ways of doing internal stretches, and they sometimes don't seem to work as well, where you're trying to press on the scapula and that. But
Ron, you talked about internal rotation deficit. Can you talk about total arc of motion real quick with that, as far as you're gonna gain a little external rotation as a thrower, lose a little internal. Can you talk about those numbers
Yeah,
real
that's a
quick?
good point. So total rotation motion and total arc of motion, if we add internal rotation plus external rotation, we'll come up with a number. Somewhere around 180, 200 is kind of typical with our throwing athletes. So we add it together, and we should be very similar to the non-throwing arm. So we've kind of have this this envelope of range that our shoulders go in. It just happens to be that envelope is kind of shifted in one direction with the throwing athletes. And so if your total motion is greater than 5 degrees different than the non-throwing arm, then that's the other red flag that the research kind of pinned down, and this being kind of the threshold point. So not only look at internal rotation, but see how that adds together with their external rotation.
Yeah, because you can't. I know in messing with it, you can't just look. Oh, you've got bad internal rotation. Well, he could have, increased external rotation, so you got a good total arc of motion that's not too bad. You got to look at each part and then the whole as well. I think to look at this.
That's a good point.
I don't want to step back for just a second to something you talked about earlier, that baseball kind of, I guess, set the trend in that we don't know a lot still today about the shoulder. We know a bunch, but we're still way far behind our understanding of this hypermobile joint that can do crazy stuff at fast speeds. But I think throwers or baseball is where we understood the kinetic chain best with that, and understanding that, the hip bone's connected to the thigh bone, and all that matters. And people don't get that a blister on your finger or a sprained big toe puts a pitcher on the DL or makes them miss a start because of the stresses and everything having to work in synchronicity to let them throw without putting themselves at risk. And even today, people don't understand, well, he just got a blister, he can't throw with that. No, he can't.
Yeah, and that blister could happen for a whole lot of reasons. It could be anywhere along the body chains, which is really interesting.
Right. I mean, from how you're gripping the ball to you got a bad ankle.
Yeah.
And so that's what, even today, even as much as we know in the 24/7 news cycle of ESPN, they still don't get, well, he got tendonitis from flicking sunflower seeds and he's on the DL. Yes, he is, because I can't think, one of the stats out of the Andrews group is 25% of the salary spent on pitchers, they're spent for them to be on the DL, and so that's significant. So.
Okay, so, well, you talked about a lot of things. You talked about the conditioning, you talked about lifting weights, and the old cliche that baseball players shouldn't lift weights, which is,
that's been shot down.
Yeah, it's been shot down now. And most baseball coaches do lift, but yet they, I see that some of the lifts are different than like footballs, but in a way the same. So you talked about the different types of lifts, and players should lift. I think they should lift more in the off season as in the in seasons, more sport specific, and do the things. And you talked about lifting in season, like, once or twice a week, and how yours alternate weights like once and then bands the next. Can you kind of talk a little bit about what your history has said about lifting for?
Yeah, so that's a good point. So I still think strength is strength, and all the benefits from strength carry over to baseball as well as it does any other sport. But we're safer in some of the things we do considering the throwing arm. So we modify bench press. We stay away from probably overhead pressing. Squats, we look and see how our shoulders are postured. And just for simplicity's sake, I think, and for variety's sake, at least where we do it, we go basic dumbbell lifts on one day for the shoulder-specific strengthening, and then band lift on the other day. So it kind of helps set up the coaches. You just set up that way too, and so it's nothing magical, but making sure we're doing some cuff activation, conditioning, throughout the week, and I think a couple times enough to maintain what they need to and not overtrain them along with the throwing that they're doing.
Hey, Ron, what two things off the strength and conditioning. Number one, can you talk about the fact that, yes, you can fatigue and overtrain the rotator cuff, that you can and create an issue by trying to do good? And then to go with that, can I learned it from you, and we've talked about it in different ways. Talk about the 2 to 3 to 1 ratio on push-pull a little bit or pull-push rather, for people to understand that and what that matters.
That's good. Yeah, so definitely when you're working out, the postural imbalances that we see for all lifters becomes that much more problematic when we're asking someone to throw. So the typical forward head, rounded shoulders, protracted scapula, all plays into this anterior chest, shoulder tightness that's developed from excessive bench pressing, postural problems, bicep curls, incline press, everything we're doing for the anterior
Computer
muscles.
use.
And we're not doing anything to the backside muscles. And so we need to get a better balance. So very broad and general statements, we typically need to do a better job of stretching the front and strengthening the back. And so we can minimize any pressive movements and do just enough to make sure we're getting scapular type work out of it, but also work our retractors, rhomboids, middle traps, lower traps. All those things are scapular retractors and help with up rotators, and lats included. So we're working the decelerator, stabilizer muscles. The kind of adage in the baseball world is you can only throw as hard as what you can stabilize against. Yeah. And so your body's not going to allow you to do something you can't control. So we got to work those control and postural eccentric stabilizers, probably more so when the throwing athlete.
So you're talking like the rolling actions and
right.
So
as many rows and that you can kind of come up with. So you can do dumbbell rows, seated rows. If you're
reverse flies, all those things.
Everything that we're asking for, and all that. If you're talking about working the core, well, I mean, you work the core with any exercise you do, and even more so here. So we want to make sure that our athletes are getting scapular retraction, thoracic extension type stuff, and not lumbar extension. So we're working and asking for a stable lumbar segment while we're getting extension and retraction in the scapulas, with our exercises. Because we can lose it quick. And
almost want to take all our coaches and make them, they have to go through many courses every year, like what I put my sports medicine 2 kids through on, the muscle actions.
Yeah, exactly.
In other words, how they know, if you want to work the rhomboids, well, what action does that? So these coaches, they have no clue as to.
Yes, they do. Just ask them; they'll tell you.
Yeah, well, yeah,
they know everything.
They know everything.
I think in most cases, we work our scapular stabilizers and core just by simply doing the exercises correctly.
Right, planking and.
Yeah. Well, even just if you're doing a row or our prone exercises, the YTWs and Ls, that's huge core exercise if we're just asking them to stabilize and hold their posture where they need to be.
Right.
Yeah, that's
you don't need extra core exercise if you're doing exercise correctly.
The key is if they just hold that, what do they call it, where you hold your belly button in and you're holding...
oh, yeah, there's a
word. Yeah, so you got abdominal bracing.
Yeah,
right.
So you get that brace and hold it. And most of them, it's the posture. They sit like this instead of sitting and holding their core up, right? So.
Ron, you talked, and I want to get to something first before this, but you talked about to ice or not to ice, and a million moms across the world are freaking right now. But let's take it a little one step back from that, and he's got it written down over there, and I saw it a second ago. What's your thought process on what they do post pitching? Does that matter determined by how many innings or how many pitches they threw that day? If they got bombed in 2.5 innings and they're out, do they do more work that day? Do you want them to do something, or do you say, hey, that bad outing was enough, or if they go a complete game, what do they do? Do you work on anything that day, the day of throwing? A lot of coaches have them go run or do those things. What's your thoughts?
I try to keep it simple and doable, so I don't think, I think you're probably overthinking it if you're saying you only threw 20 pitches and you threw 60. So I think still some type of cool down, whether it be light tubing or a jog, so just a full body kind of blood flow, I think is fine enough. And then we know that pitchers tend to lose interrotation, horizontal adduction, and elbow flexion after throwing. And so we go ahead and address that issue right away and stretch those muscles before we lose them.
Stretch them that day of?
Yeah,
okay.
Day of.
Stretch right after pitching.
Yeah.
Right.
And realistically, they could partner stretch that. They could get somebody, one of their buddies to do that.
Yeah, they could lay on the bench.
Educate more about doing that stretching instead of concentrating more of, we need to ice this shoulder and arm down right after they pitch, and then we lose that stretching. And that,
right.
leads into why they're so tight the next day. And
But I think if someone really felt like icing was that necessary after you talk to them, then I wouldn't stop them from icing. But I think we're
Stretch
sending
them,
our
then ice them,
message.
and
Yeah, we're sending our
stretch.
message. Say ice is the answer to everything.
Yeah, you don't want to live by
Sometimes.
the ice bag and die by the
Right.
ice bag, so to speak. You need ice if you had an underlying condition, but other than that, maybe just a flush.
Yeah,
is
I mean,
good.
if you really look at what depth we get a tissue decrease, 2 centimeters, does that go down to the shoulder joint? Not likely.
yeah, I was going to say that's pretty much, we covered a lot of things as far as you said, and I did want to, Bubba asked that one question. That was one of the questions I was wanting to ask about the number of innings and that. But it's been a pleasure talking to you, Ron, and I know you're we got to do the breakouts here pretty soon, and we got another one coming. So we want to give thanks for Ron and to Bubba, and this is Bill Hell and Jasmine running the things. Do we have any questions over there, Jasmine? And special shout out to Memorial Hermann, and thank you for allowing us to do this. And Sports Medicine Broadcast, this is a wrap.
Thanks, man.
Wow, that's cool.
man.
All right, appreciate it. Yeah, that's cool.
Hey, I may steal your flash drive a little bit on the laptop.
Oh, there it is.
Okay.
These are all well. Look through all this stuff if you want to.
I will.
I think the folder is sports medicine.
Right. Okay.
Keeping us on track. Jeremy was listening to the next one. Huh? Heck, I don't know. I can look and see. Might be Candace. Huh? Should be Candace, Tinimus, or whatever. Scapular fractions of the ribs. So I gotta listen to the next one.
All right, if you will, sit here.
Hey, how are you?
Good, how are you?
Good. Line up any kickball?
What's up?
Are we gonna line up any more kickball
We
tournaments?
should.
This is so much fun.
That was so smart.
That's exactly what I was gonna say. I was like, this is ridiculous. I
I
can't
had
believe
no
I,
idea.
and my husband, you met him, whatever,
Yeah.
he was out there, rugby player in college and stuff. He's like, seriously, you're sore
Mhm.
from kickball? I'm like,
Yep.
I don't know what to tell you,
It
but
was
I
ridiculous.
don't know these. I haven't sprinted in I don't even know how long.
Same here.
And I
Like,
think that
work
was
out, and I was like sore, like my abs, my
Yeah.
legs. I was just like,
Butt's all sore.
God, I'm
Yeah,
just
it was
so.
hysterical.
We played kickball in the gym before football games sometimes, and
Really?
why did I do that?
We
Yeah,
played,
it's like my glute hamstrings.
everything,
The hamstrings were just
Hamstrings
killing
and
me.
quads.
I was like, oh god.
We played it was a sponsors game over at the Skeeter Stadium. So it was
So
all the
fun.
sponsors
Gotcha.
put a team together and
We
played.
just need to have more people so we
Yeah.
can rotate because it was a long
Yeah, our
day.
first game was against Methodist.
Like,
big rival.
strategic.
Yeah, strategically
We were in the
placed.
Rivers slid into first and knocked this guy from Methodist over.
Like,
Like
what
we
are
were
you
very
doing?
competitive.
Yeah. Just
a game,
It's like you
man.
take these 10, 20 post high school, college, former athletes and you
They
put
put us
them in
all
this
together, yeah.
nobody has really any competitive outlets really anymore, and so
Yeah.
put them in this situation.
It was hilarious. I thought we were gonna have a fight.
Yeah.
He got into
Really?
his face. He's like, "What are you doing, man? It's just a game." It's like, "You shut up, you big baby."
Well, it's tall. Big baby.
Yeah, it was pretty funny.
Did you start both of those already? All right. All right, so there's a live stream. There's the video.
Oh, there's a video too. Okay.
So that's all right. So, ready? All right, so what's up, y'all? Welcome to the Sports Medicine Broadcast. This is with Dr. Candace Tunis and Stephen, what's your last name?
Ramirez.
And I'm joined with Stephen Ramirez. Leslie's been joining me. So we're here to talk about specifically scaphoid fractures and repair and those kind of things. And Dr. Tunis actually has to leave after her little session, the breakout session, so she can repair one today, right?
Yes. It's sort of
appropriate.
ironic.
Yeah.
All right, so hopefully at this point, whoever's downloading this will have already listened to the lecture,
Mhm.
because I'll take that lecture and put our interview with that afterwards. So hopefully they've already heard that. But just in case, give me a quick who you are, what you do.
Sure. Again, I'm Candace Tunis. I'm a hand surgeon with Richmond Bone and Joint. So I treat hand, wrist, and elbow injuries and issues in kids all the way up to, grandparents too. So.
All right. So hand, wrist, elbow specialist. I remember last year you talked at the Memorial Hermann this thing last year.
Yeah, I think it was. It might have
Or
been 2 years ago. Time flies. But yes, I talked when it was down at Minute Maid, and I talked just kind of an overview about hand and wrist fractures, just athletic injuries of the hand and wrist as well.
Yeah, and I know I tried to contact you, and I talked to Bubba, and at that point he said he wasn't you weren't one of his doctors or something. I don't know, because I really wanted to talk to you on the podcast, because the way that you just explain things in the session then and then in the breakout session, like, it really helped me understand, because I feel that, like, the hand is something that we don't do a very good job of understanding. As athletic trainers, it's pretty intricate, and then today you're talking about scaphoid fractures and how important it is to get that seen. And so that's obviously a big scare, is kids fall all the time.
Oh, yeah.
And one of the big things I heard you say it more than once today was that after a big fall, and if a kid has wrist pain, then you should get them checked out. So my question is, how do I determine whether I need to send that kid do I need to send every kid that falls to get checked out, or?
Yeah, I think that's a tough question. I think that's sort of the issue with these, because falls happen all the time, and I've sprained my wrist and I've broken my wrist, and they both felt exactly the same, and so it's very hard to tell the difference. I think in general, if something's lingering on, those are in particular. I mean, if it's a bad fall and they've got swelling and they've got real point tenderness, again, in the snuff box, which we'll talk about a little bit more, what that is and how to examine it. But if they've got tenderness and swelling and real limited motion, I think those kids should get evaluated right away. The one that's kind of like, kind of fell and it kind of hurts, I think you can give those a couple days or a week to kind of get better. And a lot of times, I'll see them, and people who are being vigilant will send them to me right away. And the whole thing just hurts, and you can't even tell like where they're painful. It's tender on this side, it's tender on that side, the whole thing, and and the X-rays are totally normal, and that's just a bad bruise or a sprain, and those though will get fairly dramatically better. At least most of them will within about a week. So I'll see them all on like a Friday. It's like my Friday afternoon clinic in Richmond. That's all I see is they felt Thursday night's practice. Can I play that weekend? And so if there's nothing concerning on the X-ray, if they're just tender everywhere, I mean, I'll protect them for comfort reasons. But I think those I'll re-X-ray or re-examine in a week or two. So it's kind of a convoluted answer to your question, but essentially, if they're just sort of tender everywhere, it's hard to localize, and it's kind of sore. I mean, you can wait and see if, as the dust settles, if that gets better. If they have swelling, visible bruising, and a lot of tenderness really over the scaphoid, I'd get them evaluated within the week. I don't know that you need to pull them out or something like that. But the problem happens is they fall and they have an injury in September, and it's November and it's still sore. And then they're going to, those are the ones that I see again in December or January after they're done with all their playoffs and this and that, and then I come in and it's a 3-month-old fracture. And that's the issue, is that you'd like to get them within a few weeks if you can, and it's hard to do that. And the thing is that I think a lot of times it's really coming from the kids. It's not that the trainers are deliberately missing these, it's that the kid doesn't want to get taken out. A kid wants to play, especially senior year, wants to play the rest of the season. One of my fellowship, I did my fellowship in San Antonio with Dr. Green, and a lot of times if he saw them mid-season and it was already kind of a fracture that wasn't healing, and especially with a senior last year playing, he said, go ahead, finish out the season, and we'll fix it at the end. It's the same surgery then as it is in the middle of the season. Now for that's kind of gutsy to do that, and I don't know that I don't know that I would have the guts to do that. But if it were an acute fracture, no, I'm going to fix that, because it's a whole lot easier to do it the first time around than to wait for it to not heal and then fix it.
Yeah, I thought it was interesting when you said like 40% of them, close to 40% are missed initially. It's just It's mind blowing.
Yeah.
I mean, you think that
Well,
volume and that
yeah.
rate. I mean, it's crazy.
Well, and it's a couple of issues, it's the lack of significant symptoms, and so it's sometimes it's not how bad they hurt, but it's how long they hurt. Okay, gosh, this thing is not getting better, and these are usually kids that are fairly tough, and they want to play and they don't want to complain. So, if it's this lingering nagging pain, and then you get into the issue of the x-rays look totally normal. And exactly. That's the issue from our side of it, is that we'll look at it and be like, that looks pretty good, and so that's where I think MRI is helpful. Some people talk about using using CT scans because they're certainly quicker and cheaper. The issue is you can get a false positive rate because you can, and so I don't use them. I use CTs to evaluate if they're healing. I use MRIs to.
Yeah, that's crazy. It sounds like it's not really a lack of education,
wrist pain to get evaluated. I think that's probably excessive.
Yeah.
Exactly. So.
And then, like you were saying, if we send them and the X-ray looks good, they may just go to the local emergency room. Oh yeah, there's nothing broken.
Well, and that's the other thing, is that a lot of times they'll just go to the urgent care or whatever, and they'll say, okay, it's no fracture, go ahead and go back, and then, and it takes somebody really looking at these x-rays, and then you got to get the right x-rays. I mean, I didn't go into this because it's not, we could talk for 45 minutes about scaphoid fractures, but just a basic wrist series a lot of times doesn't catch them.
Yeah.
You have to do this special view where you do what's called ulnar deviated view, which brings your hand this way, and it brings, this bone, I tell people, it looks like a twisted peanut. It's like, it's about that size.
Yeah.
And so when you do it this way, it kind of brings more of the longest portion of the bone into view, and so it's a little easier to catch them doing that view. But a lot of people won't get that. They'll just get a basic wrist series, and so some of it has to do with the quality of your x-rays and how much you're looking. And I've missed them. I looked at an x-ray and I was like, that looks normal, and then I'll get an MRI because it's so concerned. It looks so much like clinically like it should be a fracture, and then the MRI shows it, and I'm like, well,
maybe not.
Maybe not.
There's an issue.
So if a kid has a scaphoid fracture, and we tape them, would it diminish the pain or would it increase? Because usually if you press on a broken bone, it makes it hurt more.
Mm-hmm.
So, if a kid comes in and I tape him and he's like, oh yeah, it feels better now, or it gives me enough support to play.
Mm-hmm.
So that's the point where I'm not concerned about the fracture, or should I just continue to monitor?
I think you can continue to monitor that, I think anything that kind of immobilizes it will tend to help this feel better. So I don't know for certain, but I would assume that taping probably would, because some of them aren't even really that point tender over it. They just hurt, and the other thing is to watch the range of motion. If it really is painful when they move it, that's another thing that can be kind of a red flag. But I think that if taping really helps them a lot and they seem to be getting better, if they get better to a point, but they're still coming to get it taped, and it's been 2-3 weeks and they're still coming to get it taped, then if they haven't been evaluated already, I'd have them get it looked at.
Right. So what are some of the? I know you showed some pictures of the surgeries, but what are some of the current trends in fixing scaphoid fractures?
So I mean, again. For the middle of the bone non-displaced fracture, it's still somewhat debatable, and I always kind of go through the risks and benefits of surgery versus casting, because you can still cast those, and I've got some that I'm casting right now because people really didn't want surgery, and that's fine, and they will heal at the same rate, again around 85 to 90%. They'll heal. The nice thing about surgery is that surgery is putting a screw in the middle of the bone. It's acting like a cast from the inside, so you can kind of get them back doing stuff a little bit sooner than if you just casted them. As far as studies that have been done and recent stuff, I guess that's probably the biggest takeaway point that I've gotten from literature, is that earlier return to sport with fixing it for those non-displaced fractures. So that's one thing. The other thing is a percutaneous approach, and it's kind of sexy. It's kind of cool, doing it through this little tiny incision. And I think, and a lot of hand surgeons will do it that way. Much less trauma to the area. The thing is to do that, to make sure that you're doing it well that way, and I think that's the issue. And I've treated a couple of percutaneous kids that had it done percutaneously that didn't heal because they didn't adhere to good principles. They fixed it from the wrong direction based on the fracture. So I think that it's a good. It's kind of neat and it's a neat trick. But I don't do it that way. But I think that's probably a fairly current trend. Is some hand surgeons are fixing these percutaneously. I do it through a small incision. I don't think it ends up making much of a difference, but I think percutaneous fixation is another kind of current trend. Bone stimulators is another kind of question mark, and I think they're being used a lot more aggressively because they they're getting, if insurance isn't paying for it, a lot of times the company will help out and donate it. In fact, I had a kid whose insurance switched and they weren't going to pay, the new insurance wasn't going to pay for the bone stimulator, and the company just gave it to him. So there's definitely some aggressive marketing, if you will, from the bone stimulator companies, but I certainly don't think it can harm it, and I think it's a lot of times worth doing just to, again, and as I said in the talk, I throw sort of everything, including the kitchen sink, at some of these, because I don't want to be back there. I've redone them, and it's, they don't do as well. It's, you want to do it right the first time. So that's why I tend to protect them a little longer. I make sure that the screw is exactly where I want it, and I give them a bone stimulator to start, just to kind of get things going. And then I talked a little bit as far as, this vascularized bone graft. That's a fairly newer technique, not being done, everywhere. But it's kind of neat to be able to take a piece of bone. Everybody's probably heard of bone grafting. You take a little bit of bone from your hip or whatever. That doesn't have any blood supply with it. It has lots of the goodies. It has a lot of the proteins and the structure of bone to help it heal, but it doesn't have existing blood supply. But because of the way that the anatomy of the blood supply is around the wrist, you can take a piece of bone with a little tiny blood vessel attached and then move it over and restore some blood supply. So that's kind of another.
So where do they take that piece of bone from?
The distal radius. So right about in here, sort of in between this pair of tendons here. You take it. There's lots of different options for where you can take it, but for scaphoids, this is the closest. So you take it here, and then it's swung on a vessel that's smaller than that hair tie, and you plug it into the bone there, and then you fix it with a screw.
Yeah, that's amazing. Just some of the advancements that we have. We talked about with Dr. Gradia, talking the advancements in the ACL and repair, and just it's something even more specialized and localized right there, in the hand and wrist. It's really cool.
Yeah, it's fun. I mean, and that's part of the reason why I really, exactly. I love my job.
You've got a really cool, really specialized. Down to it's your hand. I mean, you use it for everything.
Yeah, you don't realize how even your non-dominant hand, you don't realize how important it is until you can't use it. It's so frustrating.
No, absolutely. Yeah, I guess some of the recovery times too.
And that's probably another thing where, as trainers, you'll see a lot of variability, and some of that is surgeon dependent, and some of that is dependent on the fracture, and some of that's dependent on the kid. So, exactly. I'm again fairly conservative. I don't want to, I've seen these things look great and then turn and look bad at so I'm for the first 6 weeks, I'd be really hard pressed to let a kid play a contact sport within the first 6 weeks. Wow. But some will let them go at like 3 or 4, with a screw in. So again, that's definitely, you're going to run into different things, and there's not really a set out sort of recommendation. I think Dr. Hildreth and I treat somewhat similarly. I think we'll tend to, around the 6-week mark, if things are looking good, let them play protected. And if it were in a non-teenager patient, you can probably put them in a splint right away. And a lot of times I'll do that, but teenagers, they're going to play.
Yeah, exactly.
So just cast them.
Are you adhering to your splint?
Right, exactly.
I'm wearing it, and then you say where's your sprint day?
Right,
You
exactly.
don't have one. It's crazy, but it takes that that total buy-in to get back to your normal, what you would perceive to be your normal state.
Oh yeah, and these just take a long time, and I mean, no matter how I tell people, no matter really how you treat it, the bone probably still takes 4 to 5 months. The thing is that the screw allows you, because it gives you that extra protection. Cast, that's all you got is the cast. But the screw gives you that added protection to allow some, at least, mobility. Does it allow contact, unprotected contact right away? I don't think so.
Yeah, probably not.
Protected contact is somewhat debatable in that first 6-week mark, but
All right, so can we go back to the bone graft? I
Yeah.
guess I'm just not in any way an expert in bone grafting because that's not something I do. But so they take a little piece of the bone off, but I would think that it would have to be similar in shape. So do they take like
Yeah.
a piece of the scaphoid out and put that new piece in there, and then it kind of grows into that shape, or do they shape that bone to fit? How does that?
Kind of yes to both of those.
Right.
So
See, I am
nailed
smart.
it.
yeah. So the times where I'm using a vascularized bone graft, or I see a kid and it's January and he probably hurt this thing in September. So it's 4 or 5 months, and I get an X-ray and you very clearly see this non-healed scaphoid. In those kids, I'll get an MRI because I want to know is that proximal fragment, that piece that's now been deprived of blood supply for 4 or 5 months, is it still alive? If the MRI shows that it's still alive, a lot of times what I'll do is I'll just fix it, or I'll fix it and do just a little bit of what's called cancellous bone graft, which basically means you either take it from, you can take it from the wrist or you can take it from the hip. It's just you sort of scrape out the innards of that bone and just sort of pack it in, and it's loose and it doesn't have any blood supply. It takes 5-10 minutes to do it. If, however, the MRI shows that there's issues with the blood supply to that proximal piece, then I'll do a vascularized bone graft, which basically means, so I'll open it up from the back, I'll clean out the area, because you can see very clearly where this thing is not healing, and then you'll have a gap usually of where it's tried to heal but it's not, and so basically you're using this little piece of bone to fill that gap. So yeah, you're not really taking out a piece of the scaphoid, although sometimes you do have to, in order to set the thing in right, to have to kind of whittle a little piece out. I mean, the piece that you're talking about is smaller than, it's about the size of your pinky nail, if that.
Wow.
So it's really pretty tiny. And then you use osteotomes, which are glorified chisels, to take out basically the hard outer portion of this bone. And again, you have this, you can see the vessel that's sitting on top, and it's giving its blood supply through that harder outer portion. And so you take that hard outer portion with the blood vessel attached, and you put it into that little kind of space that's there initially, and then you've also kind of whittled it out to make it fit properly, and then you got to trim that existing one, because inevitably you take too big of a piece, and then you got to kind of whittle it around and futz for a while until it fits right, and then you push it in, and it's kind of a press fit. You kind of push it on the top, and now, rather than giving blood supply to the bone back here, now that vessel is giving blood supply into the scaphoid itself.
So you maintain the blood vessel and just stretch it up.
Yeah, you have to kind of release it, and you're able to do this because of a lot of interconnections between the vessels. Ordinarily in somewhere you take a blood vessel out and it's not going to work anymore. But you're getting another kind of flow through another part of the wrist, because it's like a big circuit. And so the Mayo Clinic did all these studies about the anatomy, and so there's like 4 or 5 different areas you can take this vascularized bone graft and use it for different things in the wrist. And it's I think it's fairly cool, which is why I mentioned it, even though it's kind of maybe not something that necessarily need to know how you do it exactly, but it's kind of, I think, something.
That is
cool. It's cool to me. I'd like to see it done.
Yeah.
I mean, just so it was.
That was really cool.
Amazing.
Yeah, there's another issue in the wrist that happens where the lunate, where there's another bone that can actually just die for reasons that we don't understand. And that's a common reason why I'll use this. I'll use a different graft. I use one that's kind of over in the different portion of the wrist, but it's another reason why I will use the vascularized bone graft in the wrist.
Wow.
Very cool. And Jasmine over here, actually, it's pathetic, but I didn't know all the names of the bones of the wrist, which is
that's okay. No,
and it was like
2
months ago. She went to work a volleyball tournament with me, and so she knew them, and so she was quizzing me on them the whole time.
Did you learn the little fun little
Acronym.
Memory trick?
Which one?
No,
refresh our memory.
We just practice.
This is maybe borderline podcast appropriate.
It's okay. Vara was on here earlier. It's all good.
It's true. Okay. So there's 8 little bones in the wrist, and so the little mnemonic is some levers try positions that they can't handle. So the way it goes is some levers. So you're talking about the proximal row first. So scaphoid, lunate, try positions, triquetrum, pisiform, and then you go back around that they can't handle. So that they is trapezium capricum and trapezoid. So you got to know which of the T's comes next. But can't handle is capitate and hamate.
Wow. Because I do get the capitate and lunate mixed up. The rest of them I got pretty good. I just can't ever remember. But some lovers try positions that they can't handle.
And it's in the 2 rows. So
Got it.
proximal and then distal. The lunate is named lunate for a moon.
That's
So
pretty funny.
if you look on an X-ray, it really looks like a moon.
I think that's appropriate.
Okay. I was like, I don't know.
It's all good.
It helps us anyway. All right, well, we got to. I think
Sure.
they're actually waiting on you. So,
That's a wrap, I guess.
Yeah.
Let's go ahead and end on that.
That's
and on
a
the
great
high
end note. Awesome, guys.
Yeah. I will. Thank you so much. And again, I really, really have been looking forward to speaking to you. And maybe we can get you to come out sometime and speak again. So
yeah, absolutely.
It's a
I'm
real
happy.
pleasure.
I was happy to be invited back. I don't know why y'all skipped me last year. You know, it's cool. But no, I'm happy to come back anytime.
All right. Well, thanks.
No
Cool.
problem. That's the way I learned it. That's cool.
Yeah.
I mean, it's
Yeah, well, when I was cranial nerves, I know it's not appropriate.
right. Oh yeah, and then the oscillation centers around the elbow.
Good there.
Yeah.
Good there. Go check out the other ones. Jasmine, will you plug in the music player once you get it saved?
Yeah.
You doing the pee-pee dance over there?
No. Like,
Takes one, see?
yeah.
In here all by yourself?
Yeah. If it's inactive, it'll cut off, so I have to stay and watch it.
What happens when we go to eat?
Oh, we're gonna restart it after. Yeah.
We good? We done? Sleeping over here?
Yeah, kind of. Nope.
Check my phones. Charge.
No viewers, no activity there. Who's Jasmine Gonzalez? Tweeting stuff.
I don't know.
A little hood rat. All right, so we're gonna stop this one.
Okay.